wake everybody up? I do my best. Good afternoon, everyone. Today is September the 25th, 2023, and it is 2:03 p.m. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. The first item of business will be public communication. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via an online form or by telephone no later than 12:30 p.m. today. We have not had anyone register to make comments, so we will now proceed to the regular agenda. We only have one agenda item, members, and so I will lay that out and then make some opening comments. I will then turn it over to Dr. Brinson and Dr. Martin for some comments, and then we'll take comments from any of the other board members that would like to make initial comments. I do want to say that, I want you to be able to make your comments, but I want you to help me to manage this meeting because this meeting could go on for days. And I don't think any of you are ready to stay here for that long period of time. So I need your assistance when making your comments. Make them brief and concise and to the point. Agenda item number 1, discuss and take appropriate action on the proposed Central Health fiscal year 2024 budget and tax rate, including the impact of potential changes to the proposed 2024 budget, tax rate, and future delivery of health care. Members, the way I see it, based on the Travis County Commissioners not approving, they did not take a vote on our tax rate and our budget. It's not that they didn't approve it, they haven't taken a vote yet. And some of their concerns were around the fact that our contingency fund, and there were certain activities that they would have liked to have seen more plainly outlined in our budget. And some of those activities can actually cost more money to be taken from the contingency reserve. But I think based on our previous meetings, we have not been adverse to looking at and moving monies as necessary to fund those particular activities. Integral care being one, the diversion center being two. It's funny, I saw on the news that at 12 noon that their take of the criticism is that we have a $340 million savings account. And I started thinking to myself, when I was in my 20s and 30s, that's what my financial advisors were telling me to do, is to start a savings account, all right? To actually prepare for the future and not spend every dollar that we have now and wait until there's a crisis and then we have to go to the voters and ask them for more money. So we have been financially disciplined in moving money aside. In 2018, we went before the commissioners and they told us that they wanted us to stop just funding this and funding that, but to develop a holistic plan for a healthcare system. We came back, we did develop that plan with the help of the Episcopal Health Foundation. Not only did we develop the plan, but we looked at how we could implement the plan, finance it, and sustain it. So part of what we were putting aside was similar to a retirement. We know we're going to have activities after we stop working, so we know we have to pay for them. So we have to have this money available to us. We have a plan, and we have money. And that's was the reason that we set up the plan to do so. So, we're here today. We can either decide to change the fact of not increasing the tax rate by 6.5% and go to 0. And the staff is here to sort of outline what that will look like and what that will do to our future and what that will do to our future plans. Or we can continue where we are and back the budget that we've planned and outline for the county officials exactly what those monies will be used for and how those initiatives that are important to them will be added and paid for in our budget. I don't think anyone on this board has ever resisted the fact of wanting to fund those initiatives that they asked us to fund. Our questions have always been, can we pay for it legally? And if we can, it has to serve the population that we're authorized to pay for services for. It's not a grant, it's not a check. You can't just give money. It has to be spent for the services of the individuals that we pay for. So, based on that, we'll see information, we'll see changes, suggested changes to the budget resolution for everyone to opine on. And then hopefully at the end of this meeting, we will vote on a budget resolution document that more clearly outlines what we're spending our money on, how those initiatives that we've been asked to fund will be funded. And we will present that resolution back to the county commissioners, and we will see if tomorrow they will vote on our budget. So thank you for indulging me. I appreciate the time. And I would now like to turn the floor over to Manager Brinson and Manager Martin.
Thank you. No? Oh, it turned red, yeah. Okay, the reason that Dr. Martin and I decided to maybe talk to you is in no way because really we think that the way the whole plan has been presented might be kind of complicated. And so I thought it might be good to kind of just narrow it down to what it is we're actually trying to accomplish. So I'll start. So what we're trying to accomplish, I think, is something that has not been done in Austin, but has definitely been done in most major cities, which is to have an integrated health plan that included maybe partners, et cetera, but the integration was under one roof. And that's what we hope to do with this health plan. We will have one roof, and under that roof will be all of the services that they have shown us on the wheel and the cogs and all of those things, all run by the head of this group. So I don't know, Joe, if you want to pitch in.
Yeah, we had discussed,
Your microphone, please.
we had discussed other systems. I've said this before. We serve two people. We serve our patients and we serve our taxpayers. And we have to explain and understand ourselves that our mission, I believe, is to create a completely integrated healthcare system from top to bottom. The way the current system is, it's a patchwork where we don't really have truly supervisory roles, and that does not allow for accountability financially or professionally. And I think that in taking this approach to the county commissioners to say, you need to understand where we're going with this. I mentioned earlier that, when you read stuff, it's like they think we want the money to build a hospital and blah, 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 versus saying our goal, we have a hospital or not, is to provide a fully integrated system. because of the efficiencies involved in the models that have been used in other cities, where there is true accountability, there's partners who they supervise, and they have to financially reveal what they're doing. And I don't know, I wasn't at the county commissioners, but I think that, I don't know that message has been placed to them, because they look at the reserves and they say, oh yeah, well, this money, and why aren't you spending it? And I think what Dr. Bello said is very correct. We have perhaps not made clear what our plan is. And I could be wrong on that, but I think that if we explain that and say this will result in accountability, which is to the elected people, they need to show that they're not just willy-nilly raising taxes and having a hodgepodge healthcare system, which is currently what Travis County has.
Yes, and for me, I think the reason the system has never worked is because we don't have an integrated system. We'll just fund this, and then over here we're funding that, and we're giving money to UT, but we're not controlling the system. And in healthcare, it's very important that you control the system. This has been very successful in other cities, so it's a proven model. I think that our saving all our money so that we could reach the point, which we have, one, because of Austin's growth, which has increased our ability to take in money. This is the time for us to make this move towards running and controlling Central Health and what we're supposed to be doing, taking care of the indigent patients completely, and not relying on others to hopefully, fingers crossed, do what they should intuit that we want them to do. It's not working. So I just wanted to express that.
And a case in point, for example, is the respite, that we're going to spend money to build respite out. Well, who benefits from that? We're just paying for it. And the hospitals benefit from it. It's money that they don't have to pay to take care of these people. I was an ER doctor for many, many years, and these are repeat patients over and over and over again, which are very expensive to care for. A, it's inhumane, and B, it's financially irresponsible. And if we have an integrated system, they all link together so that we know what's happening. And I think that has to be pointed out very clearly to them about the fiscal responsibility involved in this process. So we're not being fiscally irresponsible, but actually quite the reverse, to provide efficiencies in the system as other hospital systems in the state have done extremely effectively. And that should really be our model. And like I said, I think that if made clear, then hopefully they might understand a little bit better.
But you've got to understand that, in my opinion, we're up against a lot of people who maybe do benefit from the disorganization of the systems that we have now. And so you hear a lot of negativity about Central Health, and the county commissioners have a tendency to go, well, if it's so possible, why didn't you do it 20 years ago? Well, one, we didn't need to do it so much 20 years ago. We were a pretty little town. And two, the nuns were here, and they were performing the duties that were with our hearts, so we didn't have that, and we didn't have the money. Now we have the money. And so the negativity that we're receiving from other people, I feel is just they don't want to change because they may benefit from our system now. But also, people are afraid of change. And as I've always said, if it hasn't worked, why do we keep doing it? This isn't working. We have got to change the model, no matter how scary it is. These things never scare me. I'm always eager to give up something that's not working and move on to try something else that maybe will.
Yeah. I came from Dallas, where I trained in medical school, and the interaction they had with the medical school, Dallas County, the services they provided, and the ability to then get the community behind them. I don't know if any of y'all have seen Parkland Hospital, but it's unbelievable. And the community sees the value in it. And I think to express the value, citizens here complain about homeless people, fentanyl use, et cetera, but it is this mishmash of systems that then open themselves to individual little petty programs that for which there's little accountability. And I would hope that in our presentation to the Commissioners Court that that could be emphasized to them. I would also like to direct that our communications partners here at Central Health, we need to be a little more diligent about getting this message out. It was, stated that, the county commissioners are elected officials. And I'd like to point out that they may not understand that Central Health doesn't have to exist. We do it because we do it and because we're in a city that believes about doing it. And that to say I have a public responsibility to be aware of the budget and demand tariffs, well, that's great. Well, we're saying that's exactly what we want to do. And I would avail our communications department to sort of make this issue a very public issue, that we are trying to do what we've been asked to do, and to the benefit of our community.
I agree with that. The Commissioners Court, I don't know how they all started, but I do know that now they're like, well, I got to keep my people happy. They voted me in. I want to stay in. I want to have this job. But we don't have that. So it would be natural that they would say, well, it's you. Why haven't you? Why haven't you? Why didn't you? Why did you? To talk about what failures we are. But instead of talking about trying to get a united message across that we all need to turn over the things we can't turn over to people who maybe can, or maybe the people who have been asked to do it, and to listen to that and to be willing to say, I'm going to take care of my community by supporting an integrated healthcare that may work or will work because it's been proven to work in other cities.
Thank you.
Yes, Ann.
I am going to go around the room, and then I will.
I'm just getting in
Come
line,
back to
that's all.
Not a problem.
You can take it whatever.
You are in queue. Manager Jones, any comments you'd like to make? If none, just say none, and we'll move on.
Well, yeah, I have a couple of comments. One is, I want to make sure I understood what I just heard, is that my understanding is the recommendation is that we look at making a healthcare district a healthcare district. I was one of those, actually, I was somewhat engaged in 2024 when the election was to come about, in which the city clinics were moved out of the city to become part of this district. And I was one who voted in favor of a hospital district. And the voters voted for a hospital district. Here we are 20 years later, and what we have is an enterprise in which we are a hospital district in name, but we contract out services. And so I agree with you, we do need a truly hospital district. However, I don't think we're going to be able to create a hospital district with recommendation, all the nuances necessary by 2 o'clock tomorrow afternoon. So I do think that, and I'm not suggesting you all are saying that, I'm just mentioning that because I do think we need a strategy to go back and look at how do we move from what citizens thought they were going to get in 2004 to where we are in 2025. I don't think we need to put blame on anyone, we just need to move that. So I agree with that. So that's one point. So I encourage that we put together a work group or something to study that, come up with recommendations so down the line we can do that. Second point is that in order to be able to meet, from what I heard, what the commissioners were asking of our last meeting, is today we need to be able to identify what it is we want to go forth in 2024 and anything within the reserves and or future plans that we can move forth, that we need to inculcate that. So I think we need a little time to talk about how do we do that today. So those are the 2 points I wanted to make, Chair.
Thank you, Manager Jones. Manager Kitchen?
Yes, I would concur that
that a longer conversation about the concept of moving more towards a district is a good one to have. I would concur that what I heard from the commissioners is, as Manager Jones said, what we need to do is identify what we're doing in '24 with more clarity and accelerate where we can. So the bottom line of what I heard from the commissioners is a pretty simple question. Why do we need a tax rate increase when we have so many reserves? Some of them do not understand that. Okay? So, and to me, the response to that is clarity. Clarity on what we're spending the reserves on. And then acceleration and spend a little faster to the extent that we can. And come back and show them that we're doing that. And then the last thing I'll say is I know that they made a number of asks that Mr. Giesland has put in front of us. I'll save my comments on those till later. I'm open to considering them, but I would suggest different wording. So,
Thank you very much. Manager Motwani?
In my time on this board of managers, I've been impressed with the ability of the CEO and staff and this board to have been able to have stewarded and shepherded a plan that was maybe not in its infancy, but something of a toddler at the time when I joined, to manifold stages of discussion, community engagement, continued improvement, and really fruition into a plan that really can serve as a North Star, and one that's so lofty because of the profundity of input, consultancy, and feedback from the community as well as experts, that it will take more than one fiscal year to implement. I fear that sort of common tropish narratives around not funding government and limiting the ability for government to be able to generate revenue for activities is way too common a narrative and way too common in the elected political arena. And I feel that we are maybe somewhat being subject to that in some ways. I think that much as Dr. Bell said, and I really appreciated the preamble of the three MDs on our board to have, three of the four anyway, to have started this off. I fear that we're being maybe penalized for being financially prudent. In a fiscal year where we've seen organizations, lose a third possibly of operating budgets or without anticipation a month before the fiscal year is over. We've had the good luck to be able to support mission critical and too big to fail initiatives here. So luckily we were here to support that because of that financial prudence. There's no reward for that. We continue to sort of be asked, but why? But why? And the answer is financial prudence. Concrete cannot drive faster. As much as you may want to build a skyscraper and have it done tomorrow, it can't happen. There are certain timeframes that are required for things to occur. In addition, this lofty plan has taken into account a lot of community feedback, and this very intelligent staff has accommodated for changes in community dynamics and demographics as the years go on. And there are actual inflection points in this plan to be able to account for those things. So if we were to be able to build a skyscraper in one day, it may not even be the right idea 6 years from now. To be penalized, or not penalized, but rather questioned in this way, I feel is unfortunate, because here there is a governmental / quasi-governmental entity operating through the lens of financial prudence and quite frankly efficiency in its ability to go beyond a fiscal year in its thought. And remember, government is criticized so much for just operating only with the blinders of a fiscal year. What can we tax and spend in this year? We don't want to fall subject to that. Here is an organization that has a strategic plan that is nearly unanimously supported by this board almost every time we vote on any element of it. and pretty clear spending paradigms on it. In fact, 2024, the first fiscal year, our healthcare delivery goes up by 500, 600% over year for 2023. What does that look like in 25 and 26? I just feel it's unfortunate to question it the way it is, and I feel that it's just an opportunity to kind of, for lack of a better metaphor, loot what seemingly is more willingly available to be able to fill gaps in a patchwork sort of manner. And I think that though we certainly believe any investment in healthcare for folks who are at 200% below the poverty level is a good investment, there are better ways to do it, more efficient ways to do it. And I encourage everyone who doubts this to really come back and just ask, hey, how much are we spending on the plan each year? What does that look like year over year? Okay, I see, I get it. Thanks, Dr. Bell.
Thank you. Manager Valadez?
Hi. I'm just seeing this right now. We did not get this delivered to us, so I have to still read it. I don't know what it says. I want to thank all of y'all for speaking out. I want to take this time to say that I've been on the board since 2015. By the time I came onto the board, all the agreements had been made with UT, with Ascension Seton, and Ascension Seton and UT made their own agreements. The public had very little to do with what was done. It was the managers, the board of managers, upon advice from their outside legal counsel and with the support of the Travis County assistant attorneys who served as their legal counsel also, telling them sign, sign, sign. I don't remember anybody except those few of us that participated in coming before the Central Health Board of Managers say, well, where's the financial accountability language? But we did say that to the Central Health Board before the signings of those documents occurred. What we have now is what was created by Trish Young Brown and her staff. And if it was inequitable when it was created, it was because it was inequitable, period. And there did not appear, if you looked at the makeup of the staff at that time, very little diversity. And I want to thank Larry Wallace for at least having been here in an executive position, because he at least showed that there's some color to what exists at the top. And Bedley, you eventually got hired while I was here in my first or second year. I want to thank you for being here and for remaining here, because Central Health has a lot of work to do. But what we don't need to be is wasteful in how we do it. Because the reason we were created by those foresighted legislators, and I'm talking about even before they went to the legislature to ask that we be created, Gonzalo Barrientos, Senator Gonzalo Barrientos, who was a state representative at the time, Wentworth from San Antonio, and Guy Herman, who was involved, Richard Moya, County Commissioner for this precinct. Those were the people that were talking about the creation of Central Health, an agency that could provide services to low-income population. I think that sometimes we forget that, because I don't see any of their names honored anywhere. And I'm just here to remind us that there were lots of people, black, white, brown, purple, that cared about what happened to the working poor, to uninsured, to the indigent, to those struggling to survive, put food on the table, and to figure out how the heck they're going to pay for the doctor's visits and medical care, hospital care. We need to continue doing that as efficiently as possible. I thought that that was going to happen under DSRIP. When DSRIP was created, we were, not me, not even as a board member, it was staff that was creating and working with partners to put together recommended pilots or projects that would help upon implementation of the goals and the language and success of the program, would be able to modify the process and the system to make sure that it was more efficient and effective in how we dealt with the poor and the uninsured and the working poor and the homeless and everybody else that needed help, because they're still there and they still need help. I asked several times, okay, exactly how did the results of those projects, how did they change the process? What have we gained by funding those, by getting federal dollars to make sure that those results were implemented into our system? And how did how did those results close the disparities gap? Because there was nobody else talking about social determinants of health at that time other than Latino Healthcare Forum. And there might be people here who think that's a bad thing, but I don't. And I'm very proud of having had the experience of being a federal navigator or being an enrollee in ACA and helping to talk to the families who had real needs in this family, in this community in Travis County. Everybody here has their own story to tell about what they have done and how they have helped everybody around them. Otherwise, they wouldn't have wanted to be on this board to make sure that we continue to act in that manner. So I thank you all for being here, and I thank you all for wanting us to continue. But what I would really like for us to understand is that I don't think that the Commissioner's Court is our enemy. And I don't think that I think we're partners, and I do think they understand what contingency reserve funds mean. I think they do. I think that what they may not understand is the inner workings of how our administration and our organization works. Because I myself find myself at a loss as to how it works also. Having asked many times for a copy of an organizational chart, the responsibilities of each of the managers and directors and executives as to what they do. But they're working on it, and they've done a great job at diversifying our staff. I still would like for us to have a lot more people put in place to make sure that they are linguistically appropriate for the population that we serve, which is the majority of whom do not speak the English language. I think that today, what we have been asked to do is consider whether or not there are some ways to incorporate more finite language, maybe for the diversion center and for what happens at the jail, of which I do believe is necessary. I don't know about 100% of it, but I do believe it is necessary, and it could be that is the case. But those people are our residents, and the people who live in the Travis County jails, and those that have substance abuse and mental and medical and physical and behavioral challenges are our population that we need to be helping as best we can and as quickly and effectively as we can, efficiently also.
Thank you.
So I'm just here to see what it is that we can do and to offer my help to make sure that we get a budget passed. As to whether or not it may look 100% exactly like what we submitted, as far as I'm concerned, I would hope that we could increase some of the spending for medical services delivery systems. I personally have a problem with giving $35 million to UT, as everybody knows, without them having some financial responsibility for spending it on our targeted population and not giving them a penny more or a penny that doesn't, because that's the wealthiest system in the state of Texas.
All right.
I look forward to a fruitful conversation today.
Thank you. Appreciate that. Manager Musaiti.
Thank you, Chair. Thank you, members. I echo your sentiments. First of all, I just want to thank the Commissioners Court and for their due diligence, for their work and collaboration. Really, since I've been on this board, I've enjoyed working with them all and our city council members as well. Now, as the initial point that was addressed about integrative health system, and we know different models of care, like Kaiser Permanente, and how they have control, and what we've lacked is absolutely control and accountability. we provide these services and who provides and how and when. And so we've struggled, but most importantly, who suffered the most is our patients. And why we're here is for them. And that's why every single one of us are investing hours, probably hundreds of hours every year, just working on this goal and mission, addressing the care for those who need it most. And I'm definitely a big support. I support the plan that we have, and in order for us to implement, we need those reserves. Without those reserves, we cannot implement this plan. A plan will just be a plan. As well, we need to think about the future and as well the present. We still have individuals who are suffering, who need care yesterday, not tomorrow. And we need to work in parallel with addressing those two services. And that is something that I believe our staff is working, and we're trying, but unfortunately, at times our hands are tied, and especially where we're at with our hospital system that we have, and the data really supported that they're not providing the care they should be providing. And what do? We have no control over that. And it's mind-boggling that we are portrayed in the media as those who are raising the tax dollars, rather than we are the ones should be portrayed as those who are really fighting for the people to provide them the care. And that's why we're here. We are here to provide everyone equitable care, and regardless of who you are and where you live, and that is our mission. And if I did not personally believe in this mission, I would not be here. I would not have spent the time that I have on this board. And to simplify the language, and that is something maybe we need to really address it in very plain language why we do. And sometimes optics can be misleading, but that is in the goal for all of us, is to think about how do we use this reserves to provide the best quality care that our population deserves, and how do we merge public health with healthcare, the public, in working collaboration with everyone at the table, because obviously we have that vision, but we cannot do this alone. We need everyone's help and everyone's support. And Chair, I definitely personally support what we've worked on for the past few years. I support the staff. We've spent tremendous hours, days thinking through the plan that has been presented and thinking about things, how do we deliver care differently. Change is difficult. Change is difficult at many times, and people are fearful. And we need to provide this care. Unfortunately, we can't control what happened in the past, but we can control what happens in the future. So with that, I hope that we can have a fruitful discussion on how we can improve the quality of care for our Travis County residents.
Thank you, Manager Musaitis. Manager Martin?
Thank you, and I'd like to second, that was very well put. I'd like to point out, when we go to Commissioners Court tomorrow, we're being asked to fund some things in a hodgepodge way, which it's always been done. Let's take over the jail, let's take over the recovery center for people who've been picked up off the street drunk. This is exactly, it's been the problem with the system, okay? We may or may not have an obligation to those patients. They may not be Travis County residents. But most importantly, this is an exact replication of what we've been asked to do with no oversight. As an ER doctor, you take a drunk off the street and you take him to a recovery center where there's not a physician who doesn't know how to intubate someone, who doesn't even recognize the need to intubate someone. We're assuming all this medical legal responsibilities with no oversight as to how the system is run, what happens, but yet there we are. And this is exactly what's been wrong, are these asks, versus saying we have an umbrella. Put it under here, and we will have a medical director who is extremely competent decide who supervises that site and what we'll spend on it. Not, you cover this, you cover that, good luck. That is not a healthcare system. And that's what we need to emphasize to commissioners. That is not a healthcare system. A healthcare system is having a wonderful medical director say, this is what we're going to do for these people. We're going to have a paramedic there who recognizes someone who needs to be intubated. We're not going to sit someone in a tank someplace and hope they recover the next day. with us carrying the medical legal responsibilities associated with that, because ultimately we're the one paying for that service. So this is a typical problem, and they're asking us to repeat it endlessly. Thank you.
And they're doing the same thing with the jail. You know, I have worked at the jail as one of their doctors for 28 years. I mean, I have a vast experience working at the jail, and I love working at the jail. But the thing that I love the most at the jail is that I can do what needs to be done. If I need a CT scan, I get a CT scan. Nobody is going to tolerate saying no to my wanting a CT scan. That's going to happen. But I can tell you that the system now, if I need to send somebody to ortho or they've got a broken arm or a dislocated shoulder, if I can't fix that, they're going to wait. And they're going to wait because that is not under the jail's purview. It's under the same people that are under that we have problems with, right? So I also have to say that it is exactly the reason why we can't perform adequately on all the other things we do. Nobody has even looked at what they're asking us to do at the jail. If I could tell you the stories of the patients I have seen and thought, holy crap, can I keep this person alive long enough to get them to the ER, and then they end up in the ICU for 3 months, and that bill is astronomical. If we're being asked to handle that kind of thing, it has been very poorly thought out. You know, I was the only person who has the experience, and I thought the meeting was an hour later, so I show up late and the meeting's happened and nobody has ever talked to me about it again. And I have to say that jail medicine right now in Austin is the best medicine there is in Central Texas. I will tell you that. Patients here, they can get medications. If you go to Williamson County and you're in the jail, they don't get any medicines. You know, I tell people, if you're going to get arrested, make sure you speed as fast as you can and get into Travis County. Because if you're not in Travis County, they're going to let you die. But the reason our medical care at the jail is so good is because every single one of us really care about the patients. And if we remove that without any thought, I mean, I just feel like this is being pushed down our throats. We haven't had any time to plan. We haven't have any time to understand what is it we're even going to agree to. You know, it's a huge, huge thing. It's a huge endeavor. So I just really would say that slowing down on some of these prerogatives that people who do not know anything about it are asking us to do would be wise. That's my thing.
Very quickly, please.
Yes, Dr. L. Thank you very much for allowing me to say a few more words. I just wanted to say, one of the things that we have, what we're experiencing today is very clear. We don't have a holistic approach to addressing healthcare. We don't have a holistic approach to looking at what the social determinants of health. What is the city? What is the county? What are the school districts? What is the higher education learning center? What is a jail? What is a sheriff's department? What do all these various components within Travis County have to do with how a person lives and the quality of life that they have here, how they work, how they live, how they get a job, how they transport themselves from one place to the other. And unless that is done in a holistic way, we're going to be pointing the finger at each other, saying it's your responsibility for that, it's your responsibility for that, it's your responsibility for that. And we are not, at Central Health, a public health agency. The city of Austin covers public health. The county covers public health. We were created specifically to address the health of our uninsured and those living under 200% FPL. That's it. Now, if there are gaps to fill for the public that would benefit from everything that we do, then we need to have the other entities at the table with us saying that this is what they are going to do in order for us to be able to know what our part will be. And I tend to agree with the fact that this is in the beginning stages. for, let's say, the diversion center or for wanting us to help with the jail, I think. But I do believe that part of that is viable and that we should look seriously at that, but we need to do it in a cohesive way, in a comprehensive manner, and with the people, all the parties together, not necessarily in this room, because I don't know if it would be enough room here. But in a place, maybe the auditorium, where we can have serious conversations about people dying and terribly every day. Thank you.
Thank you. Manager Kitchen, quick?
Very
Yeah.
quick, I think, I agree with what everybody's saying, and I was as concerned and upset and unhappy with the conversation at the Commissioners Court. But I urge us today to simplify. Let's just focus on what we need to get past tomorrow. And to me, that's pretty clear. There's a number of different ways that we might choose to do it, but it's really pretty clear, and so I hope we do that.
Thank you. Manager Jones?
I would like to echo what my colleague, Manager Kitchen, just said. We have a task we need to do today. I think we all agree that some of the discussion that our colleagues, Manager Martin and Manager Brinson, has indicated are definitely needed. And I encourage us maybe to identify a working group that will begin to look at those kinds of components. But we have a deliverable we need to have it ready by tomorrow. And so I would encourage us to just focus on how we're going to do that and what it will take to do that.
Thank you very much. And with those comments, I will turn the floor over to Mike Giesland.
Yes, and we're going to queue up the slide deck, and as we're doing that, first I want to just real briefly, for the benefit of the board as well as the public that are here today, as well as those that are viewing online, propose a run of show, if you will, Chair Bell, and that is we'll show this slide deck here, and it's what we will be presenting to the Travis County Commissioners Court tomorrow. In part, I say in part because there are still some slides that we've got data, but we're going to compile it, repackage it, present it differently. But we will show you what we have here today. And it also does double duty with this board in showing the fiscal impact of some of the changes that have been discussed, both in spending as well as potential changes in our revenue sources. So we'll go through this slide deck today. Then what we propose is that we move to closed session. We have a number of legal counsel here today to advise the board, because it's already been noted by some of the opening comments by the board members, there are legal issues around some of the changes that you're being asked to make. So that way you're fully informed by legal counsel. And then coming out of closed session, what we propose is that there are actually two working documents to present to you today. One is a list, what I call a working document. It's a list of suggested changes that we can walk through, and this is all board prerogative. These are staff recommendations that were assembled over the weekend, but we recognize that, we have to provide a starting point, but that you all have different insights and perspectives, and so we need you all to take ownership of ultimately what the amendments are on this working document, and then put those into a document that formally amends the budget resolution as well as Schedules A and B of the budget, so that we can then provide those to the court later this evening or first thing tomorrow morning at the latest. So when you end the meeting today, what we would ask is that you have a resolution which memorializes the actions that the board took in providing some background, which we'll work through today. You'll have a revised fiscal year 2024 budget resolution. That's the second document. And then third, you'll have revised Schedules A and B as warranted. Now, members, one of the questions is why are we having this meeting? And as has already been mentioned here today, we presented to the Commissioners Court last Tuesday, and there was not action taken to take a vote. We met with the judge and Commissioner Shea on Friday, and we are also in communication with other offices to put together additional information. But essentially, I'll sum it up with this. There are demands that have been made. And demands is a verbatim term. That if there is to be a vote, then these demands must be met. And I'm not in a position to advise the board that we risk or gamble our patients' well-being. Managers Kitchens and Jones are right we've got to get a budget and a tax rate adopted. And so you have no other choice but to consider changes to the budget resolution and the budget schedules. Because otherwise, who's at stake? Well, it's our patients. And I just can't use them as pawns. So with that, going through these slides. So taking this back to the performance review, and Dr. Bell, you had mentioned this. In 2018, we had a performance review that was ordered by the Travis County Commissioners Court as part of the financial policies for the oversight of Central Health. This report was performed by Germain Solutions, and there were 3 takeaways here that I won't read through all of these, but there's some key terms that jump out at you. Is that in the partnership model, what was deemed then the public-private partnership model, comes with trade-offs, and that is the control. And Dr. Brinson, you spoke to this earlier. What control do you have over the care delivery process? Second is, it was very clear, and this was noted as a national shortage at the time, it remains a national shortage. So this is not a problem that is unique to Travis County, and that is addressing physician shortages, particularly related to specialty care. While this was not opined on, while this was directly opined on in the Germain Solutions report, I would add as a footnote to that, it's not just about the physicians, it's about the care teams that support the patient, through the specialty care journey, including social workers and people to help with eligibility and enrollments. I mean, it's everybody. It's not just the doctors. Third is, and this was an assessment of Central Health's administrative structure, is that we ran extremely lean, and they noted in finance, planning, information technology, and human resources. And as we have noted many times before, we have presented budgets and this board has adopted budgets that have anywhere between 94 to 96% allocated towards healthcare delivery, and then another 4% or plus or minus allocated to administration. And we ran that as a matter of principle, but I'm here to own up to, we may have run that too long. And I've noted to this board before, one of our greatest risks is we're at risk of outpacing our own ability to support this organization. And so it is essential that we address a lot of the administrative expenditures that, again, that was noted by a third party that assessed us against other healthcare districts and other entities, that we ran extremely lean. Next slide, please. This is information that this board, as well as the Commissioners Court, has seen before. We just took it and repackaged it a little bit differently in more narrative form as opposed to table form. But again, we will have the tabular form as well. And I won't read through this slide, but it just, again, it takes all of the key initiatives as well as initiatives that the county has indicated that are important priorities for the county, such as diversion, substance use disorder, medical respite, and of course, serving those that are experiencing homelessness or unhoused through street medicine and mobile teams. Now, in addition, we will also walk through slides that show how we can support inmate health care, and we've also built into our financial projections out through fiscal year 2030 about ongoing support for integral care, which I realized from the last discussion with the board, there were, you all had asked questions about, well, is this ongoing? Is this permanent? And what we've done is, based on what the meetings that we've had with the county, is come back and actually built in a longer-term funding strategy for integral care. Next slide, please. At this point, I will turn it over to Jeff and members, and just as a matter of process here, but also an ask. There are a number of staff individuals here from the executive team that some have direct speaking roles in this presentation, if you will, but there are also a number of people that we may call up or that we've asked to provide responses to you. So allow us to play musical chairs, but also allow that safe space for staff to speak freely and candidly with the board as well. Thank you.
Yeah. Thank you, Mike. Jeff Knoll, CFO. And under the vein of trying to keep it simple, and I realize I may have violated the first part of that on this, but we will keep it simple. The next three slides, in essence, say the same thing in a different manner. And so the first takeaway on this graph, without getting into the numbers, is, and I think Manager Matwani said it really good. We can't just put blinders on, and we can't assess what happens in fiscal year 2024, because it has long-term. There's a lot of things that we've contemplated that do have long-term impacts. The whole basis of the health equity plan that you've approved is building a plan with ongoing costs year over year that incrementally increase year over year. So these are not one-time costs. These are ongoing costs that will have to be implemented and supported in a financially prudent manner. So with that said, there are in reality only two scenarios on this chart, and what I'm going to go through is what the slight changes are. This is a table format of our forecast document, and really just emphasize what's the total result of a couple of changes that have long-term impact, and what is a long-term impact. And so what are the two scenarios that we're talking about? So we're really talking about a tax rate as we've proposed in almost every forecast we've done this year, which is a 6.5% increase year over year. That model, through looking at our forecast and the implementation of our health equity plan, in addition to ongoing expenses, support the implementation of the plan, create financial sustainability, and also keep us at a level of reserves that we feel will help mitigate any either known or unknown events that could happen. So getting specifically to this table, and this is the old version. So bear with me for a second. We've got a little different version that we'll show tomorrow. The important numbers to keep in mind here are in the fiscal year 30 columns, the reserve amounts. And you see them kind of bolded there, the last two lines in the two tables. And so we've taken our forecast model and we've added the three requests that we've been discussing, inmate health, integral care, and the diversion center support. And we've added those to our fiscal year 24 model, and then we've inflated those over 5% year over year. And so you see the inflator there in kind of the grayish lines on both tables, same numbers. The only difference, excuse me, the only difference in the tables again is one is the top table is at 6.5% year over year, again, as we propose. The second table, on the lower half of the slide is if our tax rate is not adopted, I think what I heard from the county's perspective is that the no new revenue, the lower of the no new revenue rate or the prior year tax rate would be used through a ratification process. And so we've modeled that out also. I'll just say right off the bat, the difference, so the lower of the prior year rate and the no new revenue rate is the no new revenue rate. And I think, at some point, I thought I heard Judge Brown say the impact was about $30 million. That's correct. It's about a $30.6 million difference. So what's troubling about that is not only is it a $30.6 million difference in fiscal year 2024, but because we're looking out over 7 years and we're building our reserves incrementally because our spend is incremental, that the difference in 2024 doesn't incrementally increase year over year. And so over 7 years, from a reserve standpoint, the impact will be approximately $280 million less. So I'm going to go with that right now. So looking at the top table, again, this is the tax rate as we proposed, 6.5% increase year over year, fiscal year 2024 through fiscal year 30. Our sources and uses, we end up with $268.6 million in fiscal year 30, and that's what we have shown in our modeling previously. Adding the three items, the inmate health, integral care, and diversion center year over year reduces our reserves in 2030 to $171.7 million. So it's approximately, I'm just going to use kind of round numbers, around $90+ million difference over the 7-year period. So this was, again, assuming integral care would be a funding source or would be a spend year over year. When you look at the lower
So, Chair, can we ask questions now?
I think I would prefer to wait.
Okay, there's things I don't understand on this chart, so we can wait if you'd like to the end, but.
I think hopefully it gets a little easier, but maybe not. But the lower table is the no new revenue rate. And again, $30.6 million difference in fiscal year 2024. Projecting that out over the next 7 years, you see there on the very bottom in red that assuming that the no new revenue rate without the additions and a 6.5% increase year over year after fiscal year 2024, we've consumed all of our reserves. So our reserves are negative $13 million. Adding the additional request puts us at negative $110 million. So how did I get the difference of $280 million? And I'll show a graph here that hopefully will be a little more easier to understand. But when you look at the budget that we presented, again, that's the $268.6 million. And you look at the difference between that row, which is the next to the last row in the upper table, and the next to the last row in the lower table, which is simply the only difference is a no new revenue rate in fiscal year 24. The difference is about $280 million. Next slide.
Actually, before you go to the next slide, what are the two things on this slide?
Okay. I'm going to be very concrete. And again, I'm probably not understanding it. So, but just help me understand the math. In the fiscal year 30, the top column. So we're seeing an addition of 12.5 if you add the inmate health, integral care, and diversion in that last year. That's 4 plus 9.4 plus 2.7. Okay? So, I guess I'm just not getting it, because if that is, if without that addition, we have 268, wouldn't I just subtract the 12.5 from the 268 to see where I was at with reserves? To help me understand why not, because,
So that, so.
but it all goes up here too. So the whole thing, your uses have gone up to 543. Your sources are down, 506. You've gone up for your three items, inmate, integral, and diversion. If you didn't have those, your reserves would be at 268. So what am I missing?
So these are running balances, and so the difference is the aggregate sum over the 7 years of inmate, health, integral care, and the diversion center.
So the 171 doesn't represent the difference between 268 and what additional we were spending then?
Over the 7-year period, it does.
Is it because year over year,
Yeah.
the expenses are compounding and therefore there is a
Right, but
a
again,
lower
the reserves are just balances that are.
Yeah, but it
that
comes out
are-
of this reserves, not this reserves.
The reserves are a balance that just moves forward.
So what the
carries
math I
forward
should be
year over
looking
year.
at, the math I should be looking at is the cumulative of inmate, integral, and diversion across the board, but then I would subtract it from the 455, not the 268.
No, you would subtract it from the 268, so it
Well
would be
then,
the.
I mean, the 268 is what I'm sorry, I don't mean to argue, I'm just trying to understand. If I don't understand it, I'm sure the commissioners aren't either. So, I guess I'm reading this wrong. So, because I'm reading it down the column, but you're telling me I should be reading
Yeah,
across.
if I had to do it again, and if I had enough room, I would have put totals in, and that may have made it a little clearer. But we're really just carrying forward reserve balances year over year,
Right, I get that.
and,
That's the 455, 451, 425,
Right.
or
right,
the bottom line, yeah.
right. So-
But then if you take those away, you end up with that.
Yeah,
So it's all coming out of the reserves each time.
so this comes out of this though, and this comes out of this, and this comes out of this, right?
If you added, yeah, so if you,
Well, I don't want to take up everybody's time.
okay.
You
I
can
wanna
show
take-
me
I wanted to
afterwards, but I don't
understand
get
what
that.
you're
I don't get it.
So if you can explain it to me also, Ann.
I don't get the math.
Okay, so if you take the sum of inmate health,
Yes.
integral care, and the diversion center over the 7 years,
Okay,
okay, that's.
So you
going-
add up the
that-
rows.
That's going to equal about $98 million, so that's.
okay,
Those amounts inflated at 5% every year. And if you take the $98 million, that's the difference. So the sum of those three, that would be the difference in fiscal year 30 between the reserves, just as proposed, and then the last line item is the 6.5% tax rate year over year, less the accumulated total of those three items, the $98 million.
so the 268 just represents the subtraction, not counting those three.
Yes, that's correct.
Okay, that's what's not clear to me, so it,
Okay,
and
my
is so-
apologies, that's.
and the 220, so that's what's not clear, because that 268 would be if you didn't have it, and so your 90-something million, you would subtract from the 443.
Right.
Okay, and that's how you get to 171.
My apologies, we actually had 4 tables, and it was so hard to read that we condensed it down, so thank you for asking those questions.
Okay, you might need to
Sure.
do something opposite, but anyway,
Yeah.
okay.
So-
Yes, it is. Thank you very much. With respect to the year-over-year 6.5 tax rate on the above chart, and the lower chart, the no new revenues,
For fiscal year '24.
24 all the way to 30, either
No,
chart.
no.
I'm sorry.
It's
this for the
no,
re-
just
no
24.
Oh, just for 24, okay.
24.
Okay, but that's not the question. Okay, so the question I'm asking is, where are we gonna take into account that there have been efficiencies achieved? And where are we gonna take into account any protocol in the process, any protocol changes that have, impacted the number of people that we're serving and the successes of the programs that we're going to implement on lowering the numbers in the future? Because I don't see how we can look at the same numbers always being in place when what we're trying to do is close disparities gaps. We're trying to impact people's quality of life and teach them at the same time, make them more informed. That's why we have more staff. That's why we're going to have the transition of care. That's why we're going to have wraparound services. So if we take all of those additional dollars that we're putting into those programs into effect, it's almost as if there's not going to be any change. And I don't know whether I think that that's a very efficient way of us running our business. And because I believe that if we are successful in implementing these pilots and in dealing with the lives there in a more equitable manner, then we should see at some point in time improvement over year. And so where is that? How is that taken into consideration, Jeff?
Well, I couldn't agree with you more.
Yes, sir.
I think that there will be improvements. I think that's the process that we're talking about, trying to engage partners with. This financial forecast is really just it's indicative of the spend that we, Central Health, will go through based on the proposals that we received last week. So,
I thank you, Dr. Shalsha, for being there, because one of the things that this is something that you would be looking at as we grow the medical services delivery component and the increase in specialty care that we're going to be providing under community care, integral care, and through Central Health.
Good afternoon, Board of Managers. Wonderful questions. I think efficiencies will improve, but what will also improve is actually the utilization of the healthcare services. So the spend actually goes up. I think that points to the sustainability. And many of Jeff's points is as we engage more patients and we utilize our transitions of care, they will utilize the system more, and actually it will cost more. So spend will go up even though efficiencies will increase.
Okay, I'd like to have somebody, have you walk us through that at some other point. But I do think that if we teach our patients and their families how to address their medical needs, that there will be a growing number of benefits, and I would think a lessening of more serious use or more expensive services by the Central Health.
And if I could answer just one, I'll give a specific example. So
Yes,
if
sir.
we engage folks and we're able to screen them earlier, we will find things, and we will, whatever the finding is, will then have to be treated. I think to get to the golden stage, I think you're speaking to, ultimately, it'll take us years to get there. But because so
get
many
that.
people have had so little
Late start.
access for so many years, there will be a true up period, and I don't know how long that will be.
I understand, because we're just starting this, and as opposed to having started it by creating that from the beginning. So I get it. Thank you very much. But I do hope that we can see that this will happen hopefully sooner than later.
Thank you. Okay, Jeff, can you continue?
next slide. So this next slide it's the same depiction, same scenarios. It's a more graphical representation of our days of reserve on hand. Again, it's the 4 scenarios, the top line being just as we proposed, 6.5%. The orange line, the 6.5 plus the requested, the inmate health diversion center. And then the last 2 lines, the last 2 are simply the no new revenue rate in fiscal year 2024, and then 6.5% thereafter. Really, the simple difference of this is we've projected these out based on our reserve levels, and so you see from each reserve level where we end up based on our targeted days of reserve. Again, just to emphasize, the no new revenue rate is significantly impactful to reserve levels. So much to the point that if we don't make a correction on adjusting expenses in this life, we would expend, or over this forecast period, we would expend all of our reserves based on this projection.
One last question.
Before you go,
Sure.
on the chart only,
Yes.
all right?
On the chart, my concern, I don't know the Commissioners Court well, so on the chart, my concern is that they're going to look at this initially and have a very negative response because it's going to look like we don't want to do what they're asking us to do. And I know that you're like, well, that's not what this chart is meant to show, but I think if I were sitting in that position, I would be like, oh, well, you guys just don't want to do it. And I don't think we want them to have that reaction. I mean, I don't have any suggestions for making it better, but
Mr. Giesman?
Yes, understood. And you're right, this is not what this chart is intended to do. And ultimately, it's the board's call as to ultimately what this direction does and doesn't want to do. But this is, in addition to what you just saw in table form, this takes that, what you just saw in table form, and puts it in graphic form, but it's in direct response to a question from the judge, which is come in and illustrate exactly what happens if you add these, well, just come in and illustrate what happens, thinking about tax revenues, reserves, additional expenditures. And so what we're attempting to do is put this in different ways that people receive and understand and comprehend information, as well as the slide that comes after this, which is more narrative form. Thank you.
Manager Kitchen?
Just quickly, one reason I think I agree that I think it looks negative, because it assumes a couple of things. It assumes that, 2 things. It assumes that the jail services are for people that we wouldn't be serving otherwise. But what we've said is that we're talking about people that meet our eligibility for MAP. So that's one thing. The second thing is, same thing for integral care dollars. It assumes we wouldn't be spending those money otherwise in our bucket that we have for those types of services. So I share the concern that the assumptions that are built into this trajectory is probably is not necessarily what was intended by the commissioners when they made that ask. They didn't ask for us to spend more on integral care and less on other things. They just said integral care for those kinds of services, the same on the jail. Anyway, that's my take on it.
So, if I understand you correctly, Manager Kitchen, you're saying that whatever monies we give to integral care should be spent solely for our population of people. Is that right?
That's what we voted on.
Yeah.
What we voted on was that the money we spend on anybody fits our mission. So we voted on adding additional funds because we said that there was more of our mission to do with them. And, over the years, that would be the same thing. But see, over the years, we've got a pot for behavioral health and mental and SUD and that
Yeah,
kind of
there's a
stuff.
line item in our budget, had always been in our budget.
Well, and in our health equity, we're going up in that area
That's
too.
correct.
So why is it that Integral Care is on top of that instead of Integral Care is providing services in the bucket that we've already accounted for?
So you're saying that the
Not
initiatives,
necessarily for stuff that Integral Care is not doing. Now, see, I don't know what the projects are in the bucket that we projected for health equity, specialty behavioral health, and some other behavioral health things.
Right.
I don't know exactly what those projects are. There's nothing that tells me that at least some of those projects couldn't be done by Integral Care. So why are we double counting? Now, you know, I'm a person who wants to add more to that area, so I don't mind double counting at all. I don't mind double, and you know, I don't mind going
I
up
understand
in that
that.
area. It's just that I don't want this to be seen as because of Integral Care or because of jail services, we're in the red. I don't want it to be seen that way, and I'm afraid that this looks that way.
Jeff, go ahead.
If I could add, when you say in the red.
Not red, I mean below our line.
Well, and I don't disagree, Manager Kitchens, with what you're saying. I just don't know, based on the short period of time that we've had, what that number might be. Honestly,
understand.
from my perspective, we have a $7 million budgeting initiative that we're using to fill for integral care. And from a financial standpoint, we've not had near any time to evaluate that, other than saying, what I think I heard last week was continued funding. And so our assumption was continued funding, and let's at least inflate it 5% year over year simply for financial projection reasons only.
Well,
So can I sort of conclude from this discussion that the board really wouldn't like to see the graphics, but the graphics is really nothing but a graphic depiction of the chart that
Right.
you previously saw.
That's correct.
So I didn't hear the same concerns when we looked at the chart, all right?
well, I think it should be footnoted to show what the assumptions are in it, but,
The charts.
yeah. But you can footnote that.
We can-
And you could also depict the days of cash on hand with regard to each of the scenarios on the chart. Am I correct? Because that's really what we're trying to
Yeah.
show here is our targeted days of cash on hand. So you could depict those number-wise on the chart, correct?
Yeah.
Yes.
And then just not show the chart. Okay.
Fine.
I'm seeing a hand over here. Okay.
I just wanted to maybe push back a little bit on this being negative to me. And again, I look at numbers and I look at charts, and it's just what it is. This is about as dry of an assessment, plus or minus. I mean, either way, of what would happen. I see a chart shows what I see a graph that shows what the chart said. I think if it's going to be interpreted negatively, then it's going to be interpreted negatively. And I think at that point, it's in a beholder's eyes. I believe, I mean, to me, I think trying to find this number of where coincidentally from Integral Care's budget or the $7 million investment that, again, we made with very little information, where that's going to align with the growth of delivery services per our plan clearly requires more time. And I think it underscores the importance of doing as flat of an assessment as possible to be able to get as conservative of an assessment as we can, given that this happened a month before the fiscal year ends. And given in the same way that I think the notion of taking over inmate care would be happening with effectively zero study, and again, 1 month or less before the fiscal year ends. And I think that, to me, it's just numbers. I think it's its numbers and implications. If we want to do an economic study to find where, I mean, to me, it sounded like 7 million was covering a shortfall. And so a shortfall is very different from new initiatives that are being launched, as far as I'm concerned. And like the questions I have, and I'd like to maybe get into this further, is like, you know, how do we know that if, you know, our CCBHC were made whole, that they were going to solve for things like vacancies when it comes, and vacancies and gaps in the pipeline when it comes to practitioners. And things like that, but we don't have that information, right? We don't know that either. So I think this is probably the cleanest, safest way to do it, and it's the way that's most resonant for me. Thanks, Chair.
Can I say something real quick? We voted on 7 million to fund services and programs where there was an intersection between our mission and Integral Cares. That's what the language says. So it's not programs that are not in our interest. It's not programs that don't serve our folks. Okay? So my concern about making assumptions, I mean, this is just numbers, but numbers are always based on assumptions, as you know. And so whatever assumptions we make will make this look different. So we have to be clear on the assumptions, and regardless, we are in an environment where people, sadly, I mean, we already experienced this. We're in an environment where people will interpret what we put out there, regardless of its, you know, they're not interpreting what we're putting out there as simple, you know, as they should, as I would say they should. So I think, to get to the goal course, I think we better be careful how we present things.
Agreed. And I don't think that we should put an assumption in there that's not an accurate assumption. And I don't think it's a safe nor accurate assumption to take as a given that despite the fact that there may be an overlap in mission where we are doing supporting the budgetary shortfall, despite that can happen in a million different circumstances with a million different organizations, and that doesn't mean that that's part of a healthcare delivery plan. That doesn't mean that that's one-to-one direct dollars displaced, or even one-to-half direct dollars displaced. And I think if we don't have any of that data, then we shouldn't make that assumption. And I think this doesn't make that assumption. And as a manager, I'm most comfortable with it looking like that.
Well, but you are, last thing, you're making an assumption. That this is built on an assumption. So it's a judgment call. Whichever way we go, we're making a judgment call assumption. So you are looking at it one way, I'm looking at it a different way. It's still a judgment call on the assumption.
Fair enough.
Yeah, so.
Very quick, man.
Mine's going to be very, very, very quick. When they were talking, as I understood, it was my, maybe I misunderstood, but it was my understanding that if there was concern about the tax rate, it would be, let's see what you do for a year, for one fiscal year. And then you come back at 2025 and you have a better idea as to what's going on with Central Health, with the entities that we're partnering with the pilots that we're funding and moving forward, as to whether or not the same situation would be in place for the next budget year as we began deliberation on that in probably sometime in May or June. But I would think that giving them what it is that, even if it is an assumption, would be a good visual for them to have, and it would show that we're being transparent in what we're proposing, at least the forecast that's being provided to them, and they can act. They have every right to ask our CEO and staff, "What do you mean by this? What is this really going to? What impact is this really going to have on the population that we serve and the services that are provided by us?" And so, I personally don't have a problem with it, because I don't think that it's going to ultimately end up this way. Personally, I just don't. I think that it's going to be a little bit better situation. I can only hope that with all the millions that we're spending and all the programs that we're initiating and all the commitments that have been made on the part of our partners and staff. Thank you.
Mr. Geisman?
Actually, if Manager Jones,
Manager Jones? I passed my test on peripheral vision just recently, so I do have pretty good peripheral vision, but you have to keep your hand up so that I can see that it's you.
Go ahead.
thank you. So members, a couple of things here. And to reiterate, this graphic is not to make the impression, but I understand where you're coming from because impressions are important, that we can't do this. We can absolutely do the blue line, which is what the board has voted on. We can absolutely do the orange line, the next line down. There's a consequence as you get closer to fiscal year 29. And we can also do the gray line where you have no new revenue, but then you still need 6.5% year after. And the yellow line, which is no new revenue plus the additional cost, plus still needing 6.5% a year after. So we can do all of these lines. It's just understanding what the consequences are. And what I would advise this board is anytime you take a shorter period of time to go past your reserves, your targeted days of cash on hand, and you get down below that green shaded area, that's a dangerous position to be in. And if you have to go, for example, there's a lot of things that can happen between now and then that have adverse, consequences. And if you have to come in for a tax rate and you have to go out for an election and you don't get that election, will you come back up above that line? Yes, probably, but not as fast a clip as you need to. And there's all kinds of downstream repercussions of this if you get below targeted days of cash on hand and what happens to debt and obligations. But I'll reserve that for Jeff or somebody to speak to. So bottom line is you can do all four of these lines. It's just here's the consequences of it.
Got it. Manager Jones?
Forgive me, I just want to make sure I'm clear on what I have in front of me. So embedded in this are recommendations that the court has asked us to consider with regards to the, help me if I'm wrong, inmate health and the diversion center support.
And integral care,
And-
ongoing.
Well, integral care was part of ours, but the other two were part of theirs, if I'm correct. I just want to make sure.
Yeah,
Okay.
but the three are involved.
Yeah.
And the integral care, they're not just saying $7 million this year, they're saying $7 million every year.
Yeah, but they didn't say 7.4, 7.7, 8.
So what I was trying to get at is that embedded in their directions are efforts to, will result in this happening. And so in our conversation, we just need to be mindful. We're supportive. I think the CEO just indicated we can do it, but there will be impacts on funding that we have. If that's what they want us to do, then yeah, we'll do it. But these are the impacts. So I assume that tomorrow that you will share it with them. Yes, we can do it, but this will be the impacts.
Right.
Okay, so I just want to make sure I'm clear on it. One other thing is that there were a couple of other items that we have put forth in the 24 budget that I know are not large numbers, but are they reflected in what we put forth in 24?
Jeff? Yes.
So that they are incorporated in that?
Yes.
Is there the opportunity at all to be able to, as the court has done, and say we want you to do a little bit more for us to revisit that sometime today? In other words, can we go forth and say, well, we'd like to augment or enhance what we put forth in our 24 budget?
Enhance what? What?
Dollars amount.
For?
Oh, for the for instance, the Black Men's Health Clinic, we put, I think it was 500,000. The question is, can we put more in there?
Well,
Utilizing reserves.
you can.
Yeah.
You can ask for that to be
Yeah, yeah.
amended today if that's what you
Yeah,
want.
that's what I'm saying. Because what I'm hearing from the court, and what I heard the other day, is that you have a lot of money and you're not spending it. And so we want you to spend it, we want you to spend it earlier, not down the road. And so recognizing that down the road, we'll have the same, or some board will have the same opportunity to come in and say, okay, we've made all of these great advances in health in our community for our population. We want to continue that, so we might need to augment or enhance the rate at that time too. But for this time, what we're looking at is trying to get these things incorporated in the 24 budget that's projected out to 2030.
Okay, the way I understand what you're asking is that on the financials, you would like to add some, as Jeff did for integral care. So we only appropriate, are voted to include $7 million. But in his financial projections, he actually put in a inflator. Am I correct, Jeff?
On the in the forecast, yes, for subsequent years past fiscal year 2024.
Right.
For a fiscal, what you'll see ultimately, when we get to the end of the presentation, is we're requesting to increase the budget by $5 million.
Okay.
And that's the $2 million for the Diversion Center and $3 million for inmate health. So that, ultimately, that's where we'll end up on the last slide of the presentation.
If I can let you get there, right?
Well,
I'm sorry.
I think there's a
I really-
couple other.
I really,
But to his point, though, is that if we've added those, or they've been added, can we have the opportunity to do that too?
yes, but it doesn't necessarily change the amount that's going to happen in 2024. And it doesn't guarantee that it's going to happen in 2025. Because we go through the same exercise every year.
Right.
So it's only for a financial projection that just eats more away at the contingency reserve,
Right.
which causes that line to go
Right, no,
down.
I get that, but what I'm saying, we as a body are making a recommendation based upon what we see is the need. And so all I'm saying is, can all of us have that opportunity, just as the Diversion Center, somebody made the decision that this is valuable and a critical part of what we need to be doing. There are others who said there are other populations that also need to be addressed, and I'm just trying to say, can we have that opportunity now that we've opened it, it's been opened again for discussion?
But if I remember correctly, we did add 500.
We did, I'm just saying, can we not augment, because the Diversion Center wasn't part of our discussion when I voted on it the first time. And
When
inmate
you
health-
voted the budget the first time, the Diversion Center was.
I mean, inmate health.
Oh, inmate health.
Inmate health.
Okay. No, there was not a dollar amount associated with
Right.
inmate health at the time we voted for the budget.
So-
That is new.
So we're putting it in now.
Yes, correct.
And so I'm just saying, somebody made the decision to do that.
Well, it was a demand from the judge
I
who said he wasn't going to approve our budget.
I understand, I hear you. So I'm saying is, can we as board members, we have certain demands we'd like to put forth to ask that you support, and let them decide, okay, well, we don't think that's a priority.
But they don't look at the budget for that reason. We're
I-
the ones that look at the budget for that reason.
I know that, but the case can be made is that populations are not going to be supported
I see
in
you,
lieu
Manager.
of the other options. That's the point I'm trying to get at.
Thank you, Manager Jones.
Okay.
Manager Motwani.
Yeah, I feel like I see the point Manager Jones was trying to make too, and I think that just really, it's infinitely regressive, right, at this point, in the budget cycle. It should always be done, it should always be posted, it should always be thought of, it should be methodical, and otherwise, when we do it this late in the game, it's a race to the bottom. Thanks.
Totally agree. Manager Martin, I'm sorry I didn't.
No, thank you. I'd like to reiterate once again that as we tap into our reserves, we're losing sight of the mission, which is to create an integrated healthcare system. When we come with this clinic or that clinic, I need this, I need that. These things were imposed upon us by the Commissioner's Court. They weren't discussed. They were said, you do this or we're not doing this. But I think that if we don't work hard to protect our reserves and emphasize that the point of the reserves is not to tap in for little projects, but to stay focused to create an integrated healthcare system, this boat's going to sink.
Yeah.
And we need to stay focused on that, and we need to protect our reserves and explain to them, great, we'll meet you here, but believe me, we have issues with these issues, they will come back to bite us. And I don't want to give any leeway to them to lose sight of the purpose of our being is to provide health care under an umbrella for our entire needy community. And when we start picking away at things, we're going to destroy it. And I think we need to emphasize that to them endlessly. The point of our reserves is not to spend this, that, the other. It is to build a healthcare system that is efficient and equitable and humane.
And,
Thank you.
and, may I respond, please?
Yes.
And I do not disagree with you. What they would say, and the community would say, you've had 20 years to
20
do
years.
this, and you haven't done it. So now, within 24 hours, you want us to all of a sudden decide, okay, we're going to use this as our philosophy for doing business, and therefore we're not going to go forth with some initiative. I think we need to have that conversation. I agree with you. That's why I suggested we have a working group to move towards that effort. But between now and tomorrow, or this is something we need to do today. Why can we not have the same opportunity that they have to augment services and programs that are critical to this community?
Cynthia.
Okay, lastly, I just want to ask, do we have to accept the dollar amounts that they're imposing on us for this year?
Nobody is,
Give us dollar amounts.
nobody imposed any dollar amount on us, no one.
Oh, well then maybe we could change our dollar amounts. I mean,
Your suggestion?
well, so I know that we've already signed the contract on the integral care, but in Make Care, maybe we should approach it in our budget a lot slower, because you have no idea what you're getting into. I mean, it's either like stepping in the shallow end or stepping in the deep end, and this would be more like you're starting to step in the deep end when maybe you should start back around $500,000 while you figure out what they need and what our population will gain from it. I think just throwing a lot of money, if it hasn't been asked for, I just think we could go a little slower.
Let me say that I think I understand this additional money is to be for those individuals who qualify for Central Health Program.
Well, let's say that you understand it that way, but how do we know who else is understanding it that way?
And if I may ask, how have they quantified that? Is this what they've seen over periods over time, or is this just a number out of the air?
Jeff, this would be your assumption, and I mean.
I don't know that that's been determined. I think the rationale of the number was there was a budget hole that needed to be filled to fund critical services. I think there's ongoing discussions, and I think part of the resolution that was passed was that Mr. Giesland had some of those discussions to determine what those services were, kind of post-budget approval.
Which one are you talking about?
We're talking about inmate
Integral
health.
care.
No, we're talking about inmate health is the question.
Inmate health.
How do we determine
Oh, I'm sorry.
billion is going to cover
Well-
200% of poverty or below?
Right.
Well, we don't know. I mean, at some point, we heard that they were spending, I think it was almost $3
Well,
million.
I'm
on-
sure they are,
on
but
health-related
that's on
services.
everyone. And,
That's right.
lots and lots and lots of people who get arrested, they don't live in Austin.
Yeah.
Or they get arrested and they moved to Austin a week ago, that kind of thing. So they would not be eligible for our services. And so I think that we could kind of creep up on it instead of just saying, here's $3 million because that's some number we just pulled out of the air. I would go and say, what we're going to do is a study first to see, just do, a little more work on it.
So in essence, go ahead, Jeff.
Well, I just was going to respond. I think
Sure.
part of the funding is to do a study, and then I don't know what the real number is. If there's a better number, right, that's correct. But what I have also heard is that services may not be as adequate as they need to be.
Now, why suddenly that's our problem? I mean, this is funded by Travis County, yes. We have been funding the jail from the beginning of the jail system, essentially. They just don't want to pay anymore. Well, why is that? I know we have to do it because they're telling us, but I don't think we should throw all in. I think we should make a stand somewhere. Personally,
And implicit in that, forgive me, is the fact that everyone that goes to jail, I assume they think are our population.
Correct. But they're not.
That's in and of itself, the implicitness implies is a very negative implication, I think.
Yes, yes.
So I don't think that we should have some kind of data to support why we're going to fund
Exactly,
these
and then
dollars.
maybe we can figure out how much money we need.
Manager Martin?
In support of Dr. Brinson and Mr. Jones, ditto for the diversion center. I mean, those are all frat boys from Dallas drunk at Rainy Street. I mean, the city came to us and said, I think there's $3 million, right? Well, once again, are they our patients? Are they our people? And I agree. I think that's a very good point, Cynthia, that I think to say, just to sort of say, here, take the money, when I don't think, and I know they've told us to do this, but I think there is a reasoned approach to it.
And I think we could just say that is fiscally irresponsible to not know what you're spending. It's just another thing, we don't know what the money's gonna go for. That's not how we wanna run our business, and it's got nothing to do with our long-term objective.
Mr. Geisler?
Yes, managers, if I may, there's some upcoming legal discussion that I think will shed some light on this when you have the opportunity for attorney-client privilege. And Dr. Brinson, to your point, what we do is we have contracts for not to exceed amounts. In other words, the services need to be rendered, the outcomes need to be met, and then there's reimbursement that's paid up to a certain point. And now how this would work and the mechanics, given the short period of time that we have and staff, working through the weekend to figure out what's a good starting point here for inmate health, as well as that are at risk of incarceration, that are there on site, that perhaps aren't officially incarcerated. You're absolutely right. It's a starting point, but we also know there's a lot of dollars that we would utilize to enroll somebody and provide health care through the medical access or medical access basic programs if they weren't incarcerated even. So I think trying to figure out, what's the starting point for the dollars, but also recognizing that we have the opportunity to fund these individuals in the future. But also recognizing what we're not saying is just write a check for $3 million at this point, because again, to address your point, making sure that we're achieving the outcomes that we hope to achieve.
Thank you,
So
Mr.
again, just some commentary.
Appreciate it. Now, see, I went against my best judgment to allow you guys to ask questions on one chart, and here we are, it's almost 4 o'clock. Jeff, I'm not going to allow any more questions. If they're confused, they need to write notes, and we'll get to it toward the end.
I've only got one more slide, and it's simple, the next slide is simple, reiteration, just, from a verbal standpoint, what the impact of the tax rate and the reserves were, and then again, based on the proposed amounts that we've modeled for inmate health diversion. So I'm going to flip to the next slide.
Monica.
I think that's Monica.
Thank you. Monica Crowley, Central Health Chief Strategy Officer, and
Alan Shelsha, Central Health Chief Medical Officer.
so what we were looking at before really reflects the impact or potential impact by adding additional services that were not contemplated in the healthcare equity implementation plan. And the slides that we are going to present on are actually about the services and the programs that are included and that would potentially be impacted by these accepting these proposed changes. And it's not like I said, I do think in looking at that previous slide, I absolutely agree with Manager Motwani. I think that slide shows that it is possible for Central Health to take on some of those added programs. Of course, aligned with our service delivery, and as part of, and Dr. Bell and I think Dr. Martin and Dr. Brinson brought this up at the beginning, we do have a long-term plan to become a healthcare system, a proper hospital district, a proper hospital system, and that is the healthcare equity plan and the healthcare equity implementation plan that you adopted last month that consist of, it's not just one-off projects or a list of programs or initiatives. The healthcare equity implementation plan consists of 150 interdependent and overlapping projects that also include elements that cut across 38 initiatives to build an effective and efficient, comprehensive system of healthcare services that is truly focused on closing the most dangerous gaps that people that Central Health either serve or should be serving face today. And part of the 7-year incremental spend of adopting the parts of that plan that we actually can afford to adopt is a $682 million cost of implementing this part of building out a comprehensive, aligned healthcare system that helps people who today fall through the cracks and don't receive the services that they need. Dr. Shulshan?
Thank you. And as we delineate what the next steps are, we haven't been waiting. We've been rolling out kind of the building blocks and the initial steps of our healthcare equity plan. And I'll just cite a few examples. Transitions of Care has been up and running now for over a year, and hundreds of patients have been connected to disparate care environments. Respite also has been running for over a year now. We started off with 5 beds. We're now at 25 beds. We've decreased readmission within 30 days of respite utilization by up to 75%. On Monday, we opened increased access to specialty, pulmonary, GI, and podiatry with diagnostics. On November 6th, we start our direct provision of care within 3 skilled nursing facilities. In January, we start our direct provision of care at home. And in January as well, we open up an additional access to 6 other specialties. So we're not waiting, we're moving. We've been utilizing and will be utilizing the reserves for exactly the plan that Monica spoke to, for the internal build of the connected plan that really builds internally and facilitates the movement of our patients so that they don't, their care doesn't only have to exist in these disparate care environments. And the 200 positions and more that are coming on really dip into those reserves. Those positions will work the environments that I spoke to and some of the initial builds. Something that we thought was really important for folks to understand is that the delineation of the projects and initiatives that we shared already have taken into consideration the fiscal constraints that our organization has. We have decreased the rollout of services over a certain number of years. We have put off the opening of certain clinics, not because there's not need, but just because we have to pick one versus the other as we really think critically of the sustainability of this system. If we're going to build it and we're going to build it properly, it has to link, it has to have foundational aspects, and we can't set everything up and get everything up and running all at the same time. Next slide, please.
So as we developed the models that we just showed you about what the impact potentially would be of either having the no new revenue rate and the compounding impact of that. Even if you only have the no new revenue rate for 1 year, the compounding impact of not having those dollars in the 1 year and the future year. We're going to show a couple of slides right now about, and this was a request from Judge Brown, that we show what the potential impact would be if we don't have those dollars. The approach that we took, so in developing the long-term healthcare equity implementation plan, that financial sustainability plan that we, showed you before and that you adopted, we spent weeks working with subject matter experts, with providers, with direct service folks, getting impact and kind of patient journeys from people that we serve and direct service providers in determining how we might phase out or phase through the funding of the projects over a 7-year period, and the cost of both the direct service projects and additional contracted services over and above our kind of current contracts and the expansion that Jeff and Kim build into those contracted services over time. We did this exercise in about an hour and a half on Thursday, in between Thursday and Friday, because that was the time that we had. So this is very, very high level, thumb to the wind. Our general approach in taking on this work was to first start out with doing everything we can to protect services that exist today. So we did not look at cutting any ongoing services. We also wanted to avoid cuts or pushing out things like the initiatives that Dr. Shalsha just mentioned. We already have specialists hired. We need to actually open the doors to the clinics so that those specialists can get working next week. So we avoided cuts to new clinics. We also wanted to maintain planned investment levels in areas like specialty that are the areas that have the most dangerous gaps and that have been the longest standing. So, we've done a fairly good job and have been focused for many, many years on expanding primary care. We still need to expand primary care. And yet in specialty care and the performance review in 2018, and as we've continued to look, we are so heavily gapped that it directly impacts people's lives every day. And we also, of course, have the board, it is in the board's purview to review this. None of this, these are just suggestions that were made at a very high level. And we are hoping to not have to delay any of these programs because they were very well thought out. But of course, that's the discussion that we are teeing up and bringing to you. Mike, next slide, please.
So members, what you see here follows the approach that Monica laid out for the board. And again, looking at things that are still in early stages and just haven't fully launched yet, but some of the things that the board would want to consider would be prolonged or indefinite delays of various health centers. So for example, Colony Park Health Center, Health and Wellness Center, Hancock, and other projects. Just moving down to cover the larger points to summarize. Again, this is just to give you a flavor of some of the things that the board will need to consider. Elimination of not yet launched services. So if you have new substance use and detox or post-acute care or medical respite services that haven't been launched yet, and this would include future consideration of the Cameron Center, or at least put that center's future in an uncertain category. Elimination of care coordination services, including U eligibility and enrollment specialists and patient navigation centers. If you remember the COG from the health equity planning, this takes out an important piece that helps connect patients and engage patients. Across the board reductions of 25 to 40% and other initiatives that, given more time, we could, this is just an estimate on our part that we could come back and talk about with more specificity, but by time, I mean several weeks to be able to do that level of analysis. And the potential reduction of access to care. So for example, needing to look critically at Sendero premium subsidies that have yet been paid in future years, that haven't been budgeted for in future years, as well as eligibility for the MAP Basic program, potentially moving that from 200% of federal poverty level to 150% of the federal poverty level as some hospital districts have done before. So these are the sorts of things that, if push comes to shove and some of those lines on that chart are worse than what we'd anticipated, or perhaps the revenues are not there to, well, perhaps it's not the right climate to spend those revenues responsibly, then the board would need to come back and consider these. And these would rise to the level, all of them, as a strategic redirection. These are not decisions that management would make just on its own. It would take many, many hours of board deliberations to understand what the impacts are before we would ever implement on anything like this. Next slide, please.
Just tiny, okay.
I'm sorry.
This page, is this represent 7 years worth of, in other words, this is not the 30 million, this is the seven years of reduction, right?
281 million.
Yeah, right?
Over the period, yes.
Okay.
Okay.
Okay. Next slide. So we'll bring Jeff back up to walk through attachments A and B, and these are the revisions to the actual numbers, if you will, to the budget. Jeff?
Yeah, thank you. Again, just attachment A, so 2 columns, the fiscal year 2024 proposed budget, and then what we're recommending to revise our proposed budget. On attachment A, really the only difference is in the expense category, healthcare delivery. And I'll show you the detail here in just a second. In attachment B, healthcare delivery is an additional $5 million. And then the contingency reserve would be a decrease of $5 million. Next slide. And then this is the first page of attachment B. And you see it, the asterisks under the proposed budget, the additional amounts for inmate health and diversion centers, $5 million that increases the healthcare delivery amount. Ultimately on the next page, next slide, from 292 million to $297.8 million. Next slide. No changes on the next slide. And again, you see the contingency reserve at the very bottom is decreasing by $5 million to $374.6 million. Thank you.
Okay. About the chart.
Yes, attachment B, MAP eligibility increase in eligibility period is disregarding the 6 month to a year. It's only $1 million. What is this, exactly? On attachment B,
It's the
Yeah,
last
so-
line.
directs healthcare services total MAP eligibility.
So what are you asking?
I'm asking, what is this $1 million for MAP eligibility? Is that staff? I mean, what is this?
No, it's under the pretense that we are able to increase eligibility from 6 to 12 months. It would be the additional cost related, additional utilization related to that.
This is the current MAP patients, those that are enrolled. That is not for any new enrollees, which would, I guess, be then under, if they were MAP, not MAPS basic, if they were MAP, new enrollees under MAP, they would still be in 6 months, or we're gonna move everybody up to 12 months?
The premise would be if there was a change from 6 to 12 months, that there would be some increase in utilization because of the prolonged enrollment, and that's what this is for, kind of to set aside in the event that that can occur.
And this is for how many MAP patients? How many enrollees right now? Somebody can tell me that, exactly.
Yeah, about 29,000.
29,000, and that's who we're created to serve, okay?
Manager Kitchen.
Just a quick question on the slide that has, that shows the reserves. I think it may be the one before that, or,
Attachment A?
yes, okay. So, am I reading this correctly, that the first column is as we originally proposed the budget? Okay, and then the second column is with no new revenues, right?
No.
With the additional 5 million. Okay, all right.
Manager Jones.
Help me to understand, I'm having fog today, so I'm not understanding well, so I have a lot of those type of questions. These are recommendations we would be putting forth if indeed the tax rate was not approved, is that correct?
No. These are the recommendations we're putting forth to support the tax rate that we voted on and the budget that we voted on. This includes some additional items that were demands. And so that's what this change is. It's a change in the budget,
Okay,
not
but-
our tax rate.
But on this page here, where we're referring to actions of things we would do, board consideration of prolonged or indefinite delays, board consideration of elimination of not yet launched services.
Oh, so you're asking about so what is this in reference
Yes,
to? is
I'm
what
trying
you're
to find out
asking.
what is this in reference to, yes.
And I need to ask you that.
Sorry, I didn't see which page you're talking about.
It's the one,
Oh, I'm sorry, yeah.
patient healthcare services impact, no new revenue rate in FY
Yes.
'24.
So again, this is in response to the questions that we received from the court, but come in and tell us exactly what's going to happen. And so we've shown you what the dollar impact is on the slides prior to this. What this shows is it puts it in the context of initiatives and projects and also places as to the sorts of things that the board would need to consider. Again, this is not, what you see on this list is not a fait accompli. It truly is the sorts of things, examples of the sorts of things that the board would need to consider over the 7-year period.
And I agree, but the reason I raised the question was because the argument from the court, as I understood it, was you have the money to do this.
Yeah,
And so why is it that you're asking for a tax rate?
right.
At least that's what I heard to be the
Right.
That's
question.
the question.
Well, yes, also notice that if we have the no new tax, and actually, can we go back a slide, please? One more? And one more. Okay, so we just cycled through the slides, this being the last of the three, where we point out, here's what the fiscal impact is. And yes, we can fund all these things as we showed you on the lines before, and still stay at a safe and manageable position up until about fiscal year 29, which we showed you earlier. Okay, now let's go back to the slide where we were. But what this does is it says, if we're not approved for the tax rate that we've requested, and we have to live within the bounds of the no new revenue rate, and considering what's going to happen over the years, if there's any kind of deterioration whatsoever. So remember, the world doesn't follow those lines just because we drew them. Then these are the sorts of things that the board would need to come back and reflect on and deliberate as to what is it that we would need to make changes in. Now, you don't want to get here. You want to do everything you can to launch all of these. But again, answering the question, what would happen? We can't just present a single scenario without any qualifications to it and make it sound like, well, everything that we've got is going to be funded for certain, because who knows what could happen in 25 or 26.
And I understand that. I'm just saying, you're making the case here. I think what needs to be done is the court needs to hear that as well.
Yes, sir. And actually, we're going to discuss this with the court.
Yeah, I understand.
But we just wanted to
It's
present it to the
helpful.
board so that you all had a sense about what it is that the sorts of things that the board may need to consider in future years. And if I may, Dr. Bell, is there anything that I'm missing in terms of what this slide means, or perhaps even how we can reword it to make it more clear.
Well, I was just gonna reiterate again, this slide was a request, and the request was if you have a no new revenue rate in fiscal year '24, what's the impact? Again, our assumption is if we don't have the no new revenue, if the no new revenue rate is approved in fiscal year '24, it's a $30 billion impact. I think everyone agrees with that in '24. The big issue on it is what's the future impact incrementally over the remaining 7 years? And we're saying over 7 years, the impact of it is $280 million. When you look at the graph that I showed, the reserve levels, we've depleted our reserves at that level. We will have to make some adjustments on what we're spending, and that's what this slide attempts to show, some of the considerations that may be taken in order to do that. It's not definitive, it's not complete, it's just an exercise that I think we were requested to do, that we as staff did, and we're just bringing it forward.
Okay. Manager Martin, Motwani, and Kitchen, and then Valadez.
Thank you. Manager Jones, when the Commissioners Court says you have the money to do this, it's an extremely myopic view of our whole equity plan. And I think to reiterate, the reason, once again, is we have this long-range view of where we wish to go. Because we can argue till we're blue in the face, but if we stay on task that this is what we're trying to do, it's not a year-to-year thing. We have a plan in place that's already moving in place. That's our only position to take with that. So, thank you.
We understand that they don't.
That's my point, is to reiterate to them that this is why the money's there. Could we fund it? Yeah, and then we're broke and the whole system goes down. So,
Manager Motwani.
A few things. First, I just wanted to take a moment to thank the staff for everything that y'all have had to do in between Commissioners Court meetings, particularly this last one. I do find that these kinds of 11th hour requests are abusive, and I think they're a mental health issue, especially when they're compounded like this. And we're not only talking about leadership staff, we're talking about the entire enterprise staff, folks who are motivated behind projects. And there are behavioral studies out there that show how demoralized staff can become when things suddenly become derailed and shifted. And so thank you for the materials you have been able to provide us in such a short period of time. And this is also an example of what I think is often a tactic, though clearly that's not what the tactic is here, but it's often a tactic for folks who are unhappy with government or governmental entities to sort of create infinite loops of reviews and audits and cycles such that the processor overheats on that kind of administration, and then a drop may ball in the actual operational implementation. And look, see, we said you weren't doing your job, and it's because we were spinning our wheels doing meta jobs. Thank you, thank you, thank you. Now, that being said, earlier when on the slide right after the charts, I realized I spoke a little bit imprudently when I said I didn't agree that I didn't agree that the slides had a negative implication to them. I didn't when it came to the charts and the graphs, because I guess that's just how I interpret charts and graphs. But whenever I see words like lost revenue, I don't necessarily agree with that. I see that as diverted revenue from a particular plan, or I see it as revenue that's diverted from a certain type of patient care. And so I'm sorry about that earlier, y'all, Dr. Brinson and Manager Kitchen. And really, I think when it comes to sort of the implications or the adverse implications of budgetary displacement, as listed, those are pretty intolerable for me, and I would hate to think that any of the commissioners would want to vote to cut expansion of care in clinics, especially when we're hitting a wall when it comes to trying to get certain kinds of specialty care for our patients who are at 200% of the poverty level and below. And so that's a really bright line for me. So I just want to put that out there. And I also understand that those adverse implications are not hard-coded, but they are the types of permutations that we're going to have to be crafting. And I'm not excited about that. And so there's that. And then finally, when it comes to particularly the dollar amount going to integral care, and really all of those starting dollar amounts, I do agree with. I think there is some bubbling sentiment here about knowing what is the clear and direct source of the data on the startup, or at least the starting set of dollars. I do feel comfortable with those dollar amounts incrementing by whatever factor that you all have said year over year, because not born yesterday and I see how that happens. I'm assuming that there's some logic behind that, but the starting dollar amounts for the inmates as well as the diversion center would be helpful for me to get a better source of truth around that, as well as an affirmation that the $7 million for integral care are effectively restricted funds, as Manager Kitchen is saying, that are only to be used for folks who are at 200% of poverty level and below.
Monica?
Yes, so thank you so much, Manager Malwani and all of the managers for your comments. On the starting dollar source for the integral care for the jail health and for the additional diversion services or deflection services funds, I'll start with the jail health. The jail health additional amount reflects dollars for services that are provided. The source of where that came from is from the county. And
That's
so,
all I need.
And it is additional services for its people that are being served outside of the jail when they're in the jail. And I think one of the things that is important to know is that even if there are people that potentially could be eligible for a program that we would create, that would be a local indigent coverage program that could utilize contracts that we have for people that need services outside of the jail that are in the jail at that time, which is absolutely something that we can do. And that I think looking at the charts, it reflects that if our tax rate is approved, that we could, provide those services as well as the other services that we need to. We don't have, the people that are in the jail aren't receiving services through our contracts now. So that would be an add-on. I don't know if we would spend the $3 million, but as with every, kind of service contract that we have, there are not to exceed amounts. And so we would intend that there would be at least $3 million of funding that would be available for us to use our current contracts to serve the new people that would be enrolled while they're incarcerated, or folks that are on MAP that become incarcerated that also need to see a specialist outside of the jail. So the dollar amount was a dollar amount that was suggested by the county for that one. And just going, the $7 million amount, that was the dollar amount that you guys approved. And then we were asked by the county judge to consider extending that over the long term. Although there are expansions in the healthcare equity plan for the healthcare equity implementation plan for behavioral health services, those expansions were not unanimously considered to be within integral care. Some of those would be to comprehensively build out behavioral health services in primary care settings and in other settings across the entire continuum of care. So, adding an additional $7 million to our contract with integral care for, to our service delivery contract that we have with them for additional services that would be provided to our patients that are needed is something that actually can be aligned. And it is another addition financially that wasn't necessarily contemplated in the healthcare equity plan. And it's not something that is not misaligned with the healthcare equity plan. It's just something that would be an add-on. And then I think for the diversion services, we also added the additional dollars on the recommendation of the county, in addition to the kind of 500,000 to 1.5 million for diversion services that were already included in the healthcare equity plan.
Manager Kitchen.
One question, quick question and one comment. On the slide that shows, I don't have the number on it, but it's a slide that shows the impact over the 7 years. So I'm assuming that we show the 7 million as new, but it's not new because we already voted on it. So I assume that you backed it out of the 343 in order to make it show that way, right?
Yeah, we really just built this on our forecast model, so.
But it doesn't, this doesn't have the Black Men's Clinic in it, which we also voted on, or the,
Our budget does, yes.
well, so does, your budget has the 7 million in it also.
Right.
So it just.
We're just trying to show the incremental, additions.
Well,
related to
okay,
the
so
request.
I get it. I think it just makes it look like it's over and above what we have already voted on, which is not the case. So, so there's that, but, and that concerns me. So I also don't, just on the record, I don't feel like it's necessary to build in the 4%. As much as I would like that, I don't feel like it's necessary, or 5% or whatever it is. And the other question, just a quick question, is this is in addition to what we've for many, many years been partnering with Integral Care on, which is that 8.6. Do we give that 8.6 an incremental amount every year?
I think it's remained fixed for
years.
for a couple of years, yeah.
As John's coming up, may I ask a clarifying question? Would it, and I'm not sure if I'm asking Manager Kitchen this question or Jeff this question, but maybe it's pursuant to the conversation, but would it make sense to take the $7 million out of FY24 since it's in uses, take the 355.2 that's in FY24 and reduce that by $7 million?
The other thing we already voted on was the diversion center.
And this was additional diversion center funding over and above the.
2 on top of the
diversions.
1.5?
Yes, ma'am.
Oh, okay.
Yeah.
I didn't get that. I didn't
Yeah.
understand that. So I thought it was just 2. Okay. All right, so that 2 is on top of the 1.5 that's already in. The 7's already in, and the 3 is new, right? Okay. So I'm just pointing that out. I'm not going to make suggestions here that's too granular, but we're treating these differently, and it could create some confusion. So it also, well, it could create some confusion. So.
And get people off on a tangent.
Yes, and the other thing is, I as much as I would love to say that our contracts with Integral Care should have an inflator every year, that's not been our practice. So doing it this way makes it look, I know this is not the intent, and I concur with what Manager Motwani said. You guys have just done an amazing job, so please don't take it as a criticism. I've just got my impressions hat on, which is how I think people will approach things, and it looks like something we don't want to do. So then the last thing I would just say is I have some suggestions about how to present these slides in a way that's a bit more, sort of the next iteration for you guys. I mean, you've got the information down here, which is great. So perhaps we could make some changes to the slides that simplifies them some and makes the point. Things like putting the question across the top. Like that one is, that one that shows the cuts, put the question, what happens over 7 years if we have to cut 281 million? So you just put that at the top.
That's right.
And then you can, it's just, you have to, I mean, y'all have done a great job putting the information. I'm just giving you the next round of, if you did that on every page, it would help, I think. So,
Thank you. Appreciate that. Manager Melvin.
Okay, thank you. Owen with Integral Care, just another suggestion. If they were, if Integral Care was to hire some diagnosticians, they could help with kids in the various elementary schools for 17 school district in Travis County. And then those kids could receive services through the school districts and the state as opposed to Integral Care. Just wanted to say that because that sure would help with our special needs population and behavioral and mental health issues. With respect to that last slide where you have, where I asked about the MAP eligibility, all of the discussions have centered around what is our targeted population. Our targeted population is MAP. That is not our priority at Central Health. We provide services to the community, and we provide to Medicaid, Medicare, private insured, no insured, going down, all of them. And for us to have the same, I think, and I understand the discussion, we can have the legal conversation during that part of it, but I just want to say that 29,000 MAP patients is what all of this should be about. And 29,000 is not acceptable when we have 150,000, according to the 2022 Census Bureau, that are uninsured and living in poverty. And that's year after year. So what I'd like for us to do at some point in time is, again, this board has to determine whether or not we're going to address the eligibility of MAP. We have to decide whether we're going to change MAP eligibility criteria so we can enroll more people, so that our enrollers can go out there and get to these 150,000 people that don't have services. Because I think that's, for me, that's the way I would look at it as a person who desperately needs MAP services. And so all the services that we're talking about funding for those neediest of people is still about 29,000 people. And that doesn't make sense for me. And so I'd just like for us to ask this board to consider that. Thank you.
Mr. Geisler, and then I'll turn it over to you, John.
Yes, and just to clarify, we have clinical partners such as Community Care, which
Yes.
see patients from different
That's right.
payer
Sources,
models, so
right.
Medicare, Medicaid, et cetera. But really what you're looking at here is funding of primary specialty and other lines of services for MAP and MAP Basic. And so it's individuals below 200% of federal poverty level. But I wanted to clarify, and I understand what you're saying, but these other models that you mentioned, Medicaid, Medicare, that care is
models.
being provided through some of our other
Reimbursement.
clinical partners.
Right, but
Yep.
I was just listening to the words that Commissioner Trevilian was using, and tell me who you're providing services to, where they're getting located, what services are we providing, where do they live. Things like that are very simple. And it really, if the public were to pay attention to the fact that last year, the year before, the year before, the year before, since we started, we did have that $25,000 patient cap, and we were forced to live under that clause. But hopefully, it will be addressed so that it will not be hard on people like me or people that I know to know that we have not done our due diligence to rush out there and enroll those people who have not been put on the MAP rolls. And it's not a reflection on anything. We're stuck, like that's what I said, we're stuck under agreements that none of us at this table agreed to. And so what we're hoping for is that at some point in time, we will consider
that our MAP population should be our priority population, and that when somebody asks us, who are you providing services to? Are they Medicare? Are they Medicaid? Are they this, private pay? Are they no insurance, blah, blah, blah? Then we can very clearly tell them, and then they can see, oh, and our MAP population is increasing exponentially between now and the next 7 years, because that is our population that we're targeted to provide services to. Thank you.
Thank you. All right.
Dr. Bell,
Yes.
could I
Oh,
just
John,
clarify
go ahead.
a couple of quick
Sure.
things? So Manager Valadez, as you mentioned, our target population is Travis County residents under 200% of the federal poverty level. The number that I gave you, the 29,000 that was mentioned earlier, is the point-in-time count for MAP patients. On an annual basis, that's closer to 48 to 50,000 individuals, and then there's another 40 to 50,000 in the MAP Basic program. I should also mention that, as the 200% of FPL and below population, that could include individuals that are in Medicaid, in Medicare, or in commercial plans like Sendero, the 4,000 individuals that we're planning to support this year in Sendero.
But they do have other payers. So what
Yes.
I'm referring to are people who don't have other payers.
Understood.
And Jeff, I know where you are philosophically. We are in agreement, and I support. I think that you get it, and you've gone out of your way, and your staff has gone out of its way to make sure that MAP Basic existed when we push for it, and it is and should be as popular a program as we can fund, to include more people on it, because they're not bound to a 6-month limitation. They have a year enrollment to receive services under, and they're benefiting from all the services that we're growing to be able to provide to. But I just want us to look seriously at MAP. Thank you.
Thank you very much. All right. Mike, what's next on tap?
If there are no further questions on these attachments, what we recommend.
We have one question.
You can get to it later if it's appropriate later. But I think a question was raised whether there was any possibility to accelerate any programs with the use of the reserves, thinking of the first 2 years. Is that possible or not? And the reason I'm saying that is one of the major concerns that the commissioners raised was the expenditure of the reserves. And so my thought was, if it was possible to accelerate any of that without negatively impacting the health equity plan. And so maybe y'all already know the answer to that, so I'm just asking. In other words, could we show them that we're going to spend something in 24 and 25 instead of 26 and 27 or something like that? Does that make sense?
Yes, it does.
Okay.
Yeah,
does.
it makes sense.
Yeah.
I get what you're saying. I think my only question is, what kind of staffing does that take?
Right, that's,
Because, if I had, 30,000 employees, then yeah, I could do it, but I don't.
I just want to qualify that question, and I don't want to unfairly qualify it. So I think I've said that, and hopefully chair and staff will take that into consideration. But I appreciate that question, because I think that gets to a lot of the crux of what's been said. And I also don't necessarily want anybody's 1 week analysis about what that acceleration looks like as a board member. I don't want to. I think that that's a really valid question, and I think that's a really valid question when it's asked throughout our work sessions over the year, when it's asked by staffers who are coming to attend these meetings with us. I'm talking about commissioner staffers, who are coming to attend these meetings with us and walk that journey with us. However, asking that now, we could maybe get an assessment. Maybe y'all can get back to us within a week again of all-nighters, but I don't know if I even want that.
yes.
Well, then,
Thank you.
let me just, okay, I'm sorry.
Go ahead.
But I'm only mentioning this because it's a major point for the commissioners. So when we get to considering actions, perhaps we consider a commitment to do that analysis over a period of time.
There you go. I agree with that.
Agreed.
Manager Jones, and then I'll go back to you, Mike, okay?
Yes.
Just a quick question. Back to the question of the inmate services that was put up here. Is there the opportunity to maybe reallocate or re-identify, in other words, make it maybe 2 million as opposed to 3 million, and the other million reallocated otherwise?
Yeah, there is that
Will
possibility.
we have an opportunity, I guess? Sure. Okay.
Mike?
Yes. So we can always, as we begin implementing the health equity plan, but also building upon our ongoing operations, find opportunities where we can accelerate. And those will be things that and we do that now, where we would need to come back to the board and say, this is what we're doing. You've already funded it, you've already blessed it as a strategic direction, and be able to present, here's what it means to accelerate this. So that's something that we can continually do, and it's a matter of course. And that can certainly be memorialized in a budget resolution, because it's what we do now. But having said that, a couple things. One, we already took the first year, or what was 1 year's worth of implementation projects under the healthcare equity plan, and stretched them out, I believe, over a 3-year period, because there was a concern that we were going to be depleting reserves at too rapid a rate, and we didn't want to get into a position where we were standing up lines of service and creating these transformations in the system and then not have the sustainability to keep it going for patients. And that's a real concern. Once you put something out there, you never want to have to shut the doors on it. Next is, the court has asked us to fund some things, and then to start accelerating in a way that is really just guesstimating at this point, in light of, and it's not just about writing checks. You have to be engaged as partners in the development of inmate health, in these assessments, in diversion pilot projects, the staff time that's necessary, not just with the executives, but at 2, 3, and 4 levels within the organization to be able to operationalize this and do it right. And we pride ourselves in that it's, again, we'll have to see as opportunities present themselves, we take advantage of those as we have, but to commit to being able to accelerate a project, it just, without any real business case sitting behind it, would just be ill-advised at this point, I think misleading to the court and the public and everyone else.
Does that answer your question, Ann?
Well, that's why I'm saying we'd commit to analyzing it, because of all the reasons that everybody is saying. So the other thing that you raised for me, though, is the, I'm sorry, I'm just trying to ask questions that the commissioners may ask. What happens at the end of 7 years? Because in terms of sustainability, because if I'm looking at the end of 7 years, we still have a difference in sources and uses. So, and at the end of 7 years, we're down to, we don't want to go any lower than reserves. So what's the answer to that question for the commissioners if they raise that? How have we addressed sustainability after the 7 years?
Well, the answer is that it's starting to flatten out. And,
Okay.
And we feel like from an expense standpoint, that they're just ongoing and leveling out.
Okay,
And so our reserves would start leveling, and we'd start seeing that line kind of smooth around the targeted days of reserve. But we didn't run it out for, another 3 or 4 years.
yeah,
But I think that's what you would see.
okay.
If we did so.
That's fine. You may not get that question, but I just want to know what the answer was in case you did.
So it's a stabilization, stabilizes.
Yeah, it flattens. Now that's assuming that, of course, the longer you go out, the more likelihood that something may happen that you didn't know.
Yeah.
And of course, we talked a little bit about the key of 2030 being the 1115 waivers approved through 2030, and there may be some possible unknowns subsequent to that.
If I could add,
Oh, I'm sorry.
Dr. Bell, so just in addition to what Jeff was saying, by that point, at 7 years, we will have exhausted our contingency reserves above that targeted days of cash on hand. So our opportunity to build and implement new services in the system are going to be limited at that point. So we've got this 7-year period to implement the plan that you all have adopted. And then we're going to be a lot more limited and only be able to make incremental additions to our system at that point.
Thank you. Dr. Martin?
Thank you. If theoretically we obtain a hospital and we pull down federal funds, does that money come into Central Health, if that were to be the case, to build up more reserves?
I think that a discussion of anything that would be related to that, to the lawsuit with Seton would be part of the conversation with council.
Okay.
So Mike, are we ready to go into closed? Is that,
There's no further questions from the members, yes.
all right.
Clarification. So clarification, in executive session, we're talking about the legal and the fiscal implications of what we're going to be recommending, and then we have to come back out of executive session, go back into open session, and in open session, look at having a conversation about our proposed tweaks. So that's what I want to know.
In closed session, you're going to have the opportunity to consult with legal counsel on all the legal issues around some of the funding changes that we've discussed. When you come back out and open, that's where you'd actually discuss in more detail. What's the next
If there's
steps you
going to
want to
be
take?
any
Yeah, based on
modifications
what
to
you
the
just
budget that we're
heard.
going to present.
What are the
Thank-
next steps?
Thank you.
All right. Yes, I'll
But as we go in, could we have a transitional break for 5 minutes?
give you 10.
Oh, thank you, thank you.
You're all right, Doc Bell.
I'm
Thank you, Chair.
generous
Thank you.
tonight. It's your time. Is discuss and take appropriate action on proposed Central Health. Discuss and to take appropriate action on the proposed Central Health fiscal year 2024 budget and tax rate, including the impact of potential changes to the proposed 2024 budget, tax rate, and future delivery of health care. And the time is 4:45 p.m. on today's Monday, September the 25th. All right, hold on. I think we're ready.
Yeah, just read it.
We are now, I'm sorry? Yeah. Yeah, I have to get us into open. I now announce that we are returning to open session. It is Monday, September 25th, and the time is 6:29 PM. On the agenda item 1, I now will accept a motion.
I move the following motion, and I'm going to read it into the record. Add the following section to the end of section C of the budget resolution that we've already passed. Here's the language. The Central Health Board of Managers reiterates the commitment in the current budget and budget resolution to the following. Number 1, jail services. The Board of Managers is committed to partnering with the county to develop more effective and sustainable care models to address the needs of low-income eligible incarcerated individuals. The Board of Managers is committed to co-funding a joint study, including an assessment and census, with the county and other appropriate partners to assess physical, mental, behavioral, and SUD care models for serving this population. Number 2, integral care. The Board of Managers is committed to continued partnership with Integral Care and will collaborate with Integral Care to consider development of an ongoing interlocal agreement to provide mental, behavioral, and SUD services for low-income eligible persons. Number 3, diversion services. The Board of Managers has committed to $1.5 million for a diversion services pilot as allocated in Schedule B of the fiscal year 2024 budget.
Just one question. Under SUD, can you go ahead and
Spell it out.
spell it out?
Substance use disorder services. Sorry.
Okay, I have a motion by Manager Kitchen, and I have a second by Manager Musaiti. So, we're open for discussion, and managers, I'd like to say that we can edit
Yes.
during discussion, and so if you have additional issues, or you have issues with the wording that has been written, you can make those comments, and we can make adjustments, okay?
Can I make one explanation?
Sure.
Okay, this is intended to not change the budget, so it's intended to clarify the dollar amounts we already voted on.
And when you say not change the budget, meaning that
What we
it's not-
voted on last week.
Right, so it's not gonna include the things
No.
that we saw up there.
No, it does not.
Thank you for that.
Right, this is based on the previous, what we voted on previously,
That's
and
correct.
does not change those dollar amounts.
That's correct, okay. Manager Jones.
Okay, I'd like to add an item 4 to this, and that is I would like to recommend an additional $500,000 to be added to community care for the purposes of supporting and enhancing the Black Men's Health Clinic to provide additional services, additional outreach, and to work with the Latina Healthcare Forum, particularly Latina outreach efforts around focusing on men of color and non-English speaking populations for the next year's budget, for the budget that we add this to the other one, 2024.
Okay. All right. Any discussion? Any further discussion? Manager Musaiti.
Thank you, Chair. I personally agree with Manager Kitchen, just to keep the budget as is, as what we voted. I'm not in favor at this time of changing the budget that we have already approved. So that's where I stand.
Okay. Manager Kitchen.
I would like to add another number 5 for people's consideration, and that is the Board of Managers commits to an analysis of the ability to accelerate over a period of time the implementation of our health equity plan.
Okay. Any additional, Manager Ballard?
I just wanted to ask, the maker of the motion,
Yeah.
where you say, input of health equity plan commits to an analysis of
Implementation.
of the health equity plan, and projects that would, because we may be talking about at some future
Yeah.
about a project that has not been included in those 150.
Okay.
So, and projects that would
Further.
contribute to, that would further contribute to the creation of a more equitable healthcare system.
That's fine.
Will we be discussing the amendments all at the time or voting on them at once, or would this be voted on in block?
The way that we have outlined it, and David, correct me if I'm wrong, the motion that's been put out there contains all of the information that we wanted to make a change on the resolution. If there are, I think what you're asking me is if there are items that we've discussed about adding, then in essence, is there a way to separate that vote?
Yes.
So that you can say, I want items 4 and 3 and 5, but I don't want 1 and 2. David? Do we need to, does she need to rescind the motion or modify it in a way that we can
Don't
do
think so.
that or no?
Oh, I'm sorry. I think you can divide the question, can't you?
Typically, as amendments are offered to a motion, so the motion was made and seconded. The motion now belongs to the body. It doesn't
Okay.
belong to the maker anymore. You can, by accession, you can say, or you can accept, and the maker can say yes, and the seconder can say yes. Does anybody object? No. You've essentially walked through the process. But typically offering amendments, it's one at a time, and the body either exceeds or says, no, I want to vote on that one. So you can call it out, but it's also very easy with the movement accepting it and the person who seconded also accepting. That's usually the process in a, as Roberts puts it, a small body. This is considered a small body in Robert's world.
If I'm hearing you correctly, then what we would do, we have a motion on the table, which is the first 3.
That's correct.
And then we had a proposal for 4.
Correct.
So maybe we vote on that one separately, if someone wants to vote on that separately. And then we had 5, which we could vote on separately if people want to. And then it goes into the motion, the main motion, if it's.
Do we have the ability to discuss the said amendment that I maybe want to
Yeah.
pull before we vote?
Oh, yeah.
Yes.
Yeah,
Yes.
Can I do that now?
Well, let me
finish getting your.
So in essence, what I would do is I would take number 4 as a motion, an amendment.
You would always do the amendments first,
All right.
because everything else affects the main motion, which gets voted on last.
So
I'm sorry. Yeah, what were
number
you
4 would have been an amendment. Do I need a second for that?
Second.
Yes, you do.
I'm asking.
It helps.
It
So
helps.
yes, because then basically what you're doing is you're making amendment motions subsequent.
All right. So I have an amendment to the motion by Manager Jones. I have a second by Manager Valadez. So now we're open for discussion of the amendment. Dr. Martin.
Thank you. I'd like to speak not against the spirit of Amendment 4, but rather in the mission of Central Health. And we had already allocated an additional $500,000 at our other meeting. And my fear is that as we keep separating these things, we're not staying on our mission, to where everyone has a pet project, I could say. I firmly believe in the necessity to address this population, but I don't think that adding money without proof after the 1 year that we discussed at our previous budget meeting to look at the data, to look at the numbers that had returned, and then to decide whether or not to fund more. Thank you.
Thank you very much, Dr. Martin. Manager Jones. Oh,
Oh, I was wanting to respond.
That's what I was gonna say, I
Okay,
recognize
thank you. I understand your point, Manager Martin. I guess my question is, one is the initial $500,000 was not really an add-on. It was basically 500,000, which was an additional roughly 280,000 would be the additional that was added. We had already had in the budget 200. What the, we have, it's been provided to you.
290.
I'm sorry?
I thought it was 290.
290, an outline of what those other activities were, which the other 500,000 would support. So that's why I say it's an augment to what they are already doing, significantly more. Not only are they going to be doing it with black men, but we said men of color, and they're going to be outreach, there's going to be service providers. So the original only provided for one clinician. The challenge with the clinician was finding someone who would come and work in the clinic to provide those services. This gives the ability to provide 2 or 3 clinicians, one being a medical physician who would be staffed there to be able to provide the more extensive services for men of color. We particularly spent a long time earlier talking about jail health. The largest portion of men in jail are men of color. This program goes a long ways to be able to intervene and to address health needs of those who are going in the system and those who are also coming out of the system. It also gives the ability to do particular navigation in terms of the community. One of the big things we see in the community is a lot of men of color do not understand how to understand the system. How do you get in it? But also to be able to go to places where services are being provided and to do those screenings, those testings there. We do need to augment services. I do not think that this effort is separate from what we as Central Health are committed to do. We can do it in different arms and legs and hands. We don't all have to be under the same rubric of just Central Health. So I think this goes a long ways to addressing what we're trying to do as Central Health. And as we look at the big picture that we've talked about earlier of what Central Health will look like as a hospital district, then maybe we will revisit it at that time. But until such time we get there, I think we need to be able to provide these unique opportunities for services.
Thank you. My point was at our last, when we discussed the need for more providers specifically, it was for us to pick up the tab from community care if the physicians were not busy, to follow the data for the year and see what happened. We're still doubling the budget to $500,000 to provide providers and to see if the clinic, because the utility was so low about where we're going to spend our money. And the impression I was left at our last budget meeting, at the budget meeting, was that this would go to essentially to provide for pickup. If the physicians go there, they don't see patients, that we would then pick up that tab. That's how I last.
Well, at the last meeting, we clearly said that there was to be hire a clinician, meaning one. And that's what the goal is to do was then. But the reality is that the goal is much larger than that. And so we're seeing the opportunity to reach out to other communities of color, men of color, to be able to do that. This is a unique opportunity to do that. We have developed models within at least the Black Men's Health Clinic has developed models to do that. The question is, we need to give them the dollars to be able to augment that now, since we've already begun the process. We're not asking for a complete staff. We're only talking about a total of 2 or 3 clinicians that would be part of this effort, as well as the outreach components as well.
Right, but we're going from $289,000 to over $1 million.
No, we're roughly adding about a total of about 700,000 additional dollars, not just $1 million.
And my only point is that I think that should be entered more cautiously because it's a lot of money. And once again, to me, we have an umbrella that I hope we can stick to of delivery of care. And we're not having this discussion about the clinic in Del Valle or whatever. This is a whole separate entity again, and that's simply my point.
But I remind you that the reason we're doing this is that we look at the mortality morbidity rate, as I said earlier, This population by far has the highest. This is an intervention methods to be able to do that, but we want to do it thoroughly. Yes, we've been at it a year, but the first year proved that we can do it. Now the question is, can we step it up? And this will allow us to be able to enhance that and step it up.
Manager Brinson?
So my comment on this is that we're unable to discuss this in a rational way, in that we're all tired. We've had to decide a lot of things today, and having this added on at the last minute, I don't think that we're able to have a sufficient discussion to actually make the move, make the call. That's my feeling. And
Thank you, Manager Brinson. Manager Valadez?
When I was interviewed to be a member of this Board of Managers, the commissioners asked me very clearly whether or not I had the time, the energy, and the effort to commit to being here at our meetings and to engage in the discussions and take action on those votes that we needed to act upon in order to provide services to our community. At that time, there was very little, if none, like I said earlier, use of the word social determinants of health, equities, disparity, closures. That didn't exist until I came onto this board in 2015. The only other person that had brought that up, and that went nowhere during his last year, I guess, as a vice chair for Central Health, was Frank Rodriguez. And he was the last person, and then I came on 2 years later after he was there. And this was not a conversation that was easily accepted or adopted. What Shannon is trying to get us to understand is that we have been fighting a systemically racist system that everybody acknowledged from day one was dysfunctional and not providing the services that we needed to at the time. Those were the words that were used by Trish Young Brown. This is a dysfunctional healthcare system. It's a process that is not working. And one of the reasons that we pushed for an equity plan to be created, for an equity council to be created, for champions that would push for Central Health to be created, was the knowledge and the understanding that as we all looked at George Floyd, or we looked at the increased number of Black and brown and non-English speakers, immigrants, detainees, being mistreated and abused by our systems, we wanted to change that within Central Health and be a model for what is best for us to incorporate into how we operate for our people in Travis County. So what I would ask you to do is to please understand the inequity that we are continuing to deal with as we look at not only something like what Shannon is asking for not only Black men or African American men, but for all men who are the last people who want to go to a doctor because they're too busy working. And with the positions, the population that he is trying to bring to the table, those are people who aren't working. They're in the streets. They may or may not be literate. They're at the end of their ropes. And we're trying to throw them additional resources that have not been previously afforded to them because they were having to overcome a difficult eligibility criteria that Central Health had put in place for them to even be enrolled in MAP. And we know that for a fact. So we are making great efforts and great strides to overcome that. And I'd like to make sure that the public knows that there is a Black men's clinic that doesn't only deal with Black men, Latino men, Arabic men, any population, especially those that may not speak English, detainees, asylum seekers, blah, 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 that are out on the streets waiting for their hearing to occur. and who need an additional helping hand, 2 hands at least. So please consider that. Thank you.
Thank you. Manager Musaiti, any discussion on the amendment that's on the floor?
Can I add
I think you mentioned something before. Go ahead.
This is related to what number?
The Black Men's Clinic, number 4.
No
Yeah.
comment.
Okay. Manager Motwani.
I echo my fellow board manager sentiments on wishing that there could be a better way to do this procedurally, especially given the heartburn and sort of distaste for last minute adaptations to the budget. And if there were any place I would ever make an exception for such a process, it would be toward the improvement of our delivery of services to our Black and African American population, be it men, be it women, where the disparity numbers are just simply unforgivable, especially when compounded with the context, both locally, nationally, and worldwide, of how we've iterated anti-Blackness over the past 400 years and more. And so those are my thoughts. Thanks, Chair Bell.
Thank you. All right. And I would just like to say, Shannon, I think you know that I have supported the Black Men's Clinic since its inception, so to speak. I do feel that we made a commitment to put the physician in place and to make sure that they had a larger number of hours, because I was under the understanding that the outreach that they were doing was actually bringing more patients into the Black Men's Clinic, but there's no one to see them, okay? And so I personally felt that we should look at the outcome of those additional dollars prior to adding more funding for outreach. Because in essence, what we're trying to do is balance both the outreach and the clinical services, and then looking at that outcome. So for that reason, I have a concern about adding additional for the outreach when I'm not quite sure how much they're able to handle, all right, on the clinic side. And that's my thoughts.
Well, the dollars that we're talking about, additional dollars, are not for outreach. They're for additional clinical staffing. So more than just one clinician, a nurse practitioner, a physician, and others. You're familiar, $250,000, which roughly, or $280,000 was roughly what was going to come of the other $500,000, is not going to be able to provide you with another clinician or another 2 clinicians. So this money would be able to augment that. In addition to that, we've mentioned some other services, mental health services and the like, that will be provided there at the location. So the dollars, these additional dollars, are not just for outreach. The outreach is already there. This is for the clinician piece, for mental health services and for medical services there at the clinic.
So the additional monies would be targeted toward additional medical services
Exactly.
and not more outreach.
Not more outreach. The outreach services are there. What we're needing are doctors and the nurses and medical staff to be able to facilitate the clients that are beginning to come in.
Okay. Thank you. Manager Kitchen.
I am in support of this, based on the explanation that this is for additional services, whether those are physical, mental, behavioral, whatever's needed in terms of additional services in the clinic. So, and again, I share everybody's concerns about, doing things at the last minute like this, and I respect that, but I feel like when it comes to disparities like this, I feel comfortable going ahead.
All right, I'd like to take a vote then. We're voting on the amendment. All right, and the amendment is amendment number 4. It was proposed by Manager Jones. it adds $500,000 additional to community care to be utilized for increased clinical, mental, and behavioral services to be provided at the Black Men's Health Clinic. Am I correct? That is correct. Okay. All in favor? Okay. You got that, Brianna? All right. All opposed? You've got Manager Martin, Manager Princeton, Manager Musaitis. Any abstaining? Motion carries.
And on behalf of the clinic staff and the communities of colors, we'd like to thank you because this is a model that we're going to build, and I think you'll be quite proud. Thanks so very much, board member.
Thank you. Manager Kitchen, well, first of all, Manager Valdez, what do you need?
I wanted to add something to the list.
Okay.
And the only reason I wanted to add it is because it was originally in our budget. And it has been changed for us right now.
I'll get that to you.
Okay, thank you.
Manager Kitchen.
Yes, I had proposed item number 5. Okay, let me see if I can say it again. It was the Board of Managers commits to analyzing the ability to accelerate over a period of time implementation of the projects in the Health Equity Plan and other programs that support the goals of health equity,
A more equitable healthcare system.
that support a more equitable health system.
Okay.
Okay.
Do I have a second?
Second.
I have a motion by Manager Kitchen and I have a second by Manager Valadez. This is an amendment to the original amendment, number 5. Any discussion?
I will explain it.
Yes.
My intent here is just to clearly state the interest in accelerating, understanding that we don't know that we can do that. That's all. Okay.
Any further discussion? Hearing none. All in favor? The vote passes unanimously. Okay. Manager Valadez.
I'd like to propose a number 6, item 6. And item 6 is with respect to the MAP eligibility increase in eligibility period. That's on attachment B, revised. If you look at the sheets that we received today, the revision has 1 million for 23 budget. I'm sorry, that was proposed. And then the revised budget has 1 million. At a previous board meeting, we received packets, we received information here that had it at 2 million. It was at $2 million. It was 1 million and then it was at 2 million, okay? So I'd like for it to return to the $2 million amount.
Okay. So,
And that's what I'm asking for.
so number
Now-
6 is the addition of an additional
Back to
$1 million
the $2 million for the
to line item
MAP eligibility increase in eligibility period. That's in attachment B. It's right above total healthcare services. That's when I asked for clarification on how many actual MAP patients we have. And I know it's a fluctuating number, but the hard census number for our MAP population is 29,000, although it may fluctuate to up to 40. So I
Okay.
put that in.
So I have a motion. Do I have a second?
I'll second for discussion.
Okay. I have a motion by Manager Valadez. I have a second by Manager Matwani. And again, this is a discussion on an amendment, number 6, that adds an additional $1 million to the line item of MAP increasing their eligibility increasing the eligibility period. All right, Manager Kitchen.
Oh, this is just a notation that, number 4 and now number 6, if they, if, assuming that 6 passes, will also require an amendment to the budget.
That's
Number
correct.
1, 2, 3, and 5 do not.
That's correct.
Okay.
Manager Motwani.
So with respect to the most recent amendment proposed anyway, curious, I would like some staff input or guidance around, just the notion of the 2 to 1, the 2 million to 1 million, and or, just any context around that to help inform this.
The 1 million is there in the event that circumstances allow us to go from 6 to 12 months. But adding another $1 million, I'd have to defer to staff to see, is there any kind of analysis that's out there that suggests that 1 million should be increased to $2 million? Because we're already providing care for MAP patients and MAP basic. Well, this would be for MAP because MAP basic's already 12 months, but already providing care through the other lines of services that are allocated in the budget. But I'll defer to staff for a more technical answer.
I just wanted to provide clarification. Right here, if you look at our 2023 approved budget, we had a $2 million amount allocated, and now we took away $1 million for 2024. So as we look at that, cutting in half the amount of money that was supposed to go towards providing additional eligibility services for our MAP population, I just want you all to consider that.
Well, and what I'm asking is to explain
Staff.
that change, if you will.
Monica, Jen?
So I would say there is no analysis that would support having $2 million in the budget for the expansion of eligibility from 6 months to 12 months. Central Health is unable to unilaterally make that eligibility happen. And in the past, when we have conducted studies of the possible financial impact of increasing MAP eligibility from 6 months to 12 months, there have been kind of different outcomes in those studies of the actual impact of what that expanded eligibility is. I know we've discussed this before many times, but many people who are utilizers of MAP, who have chronic illnesses, re-enroll. And if they don't re-enroll continuously in MAP, they re-enroll within 45 days of when their eligibility ends. So the fiscal impact of expanding from 6 months to 12-month eligibility may not be as much as one might anticipate, because people that drive cost and are utilizers stay continuously enrolled. So I think the board continuing to advocate for that continuous enrollment is something that I think no one on the Central Health staff would
Be against.
be against.
One question about what you said, Monica. You said that Central Health could not increase increase the eligibility unilaterally. Could you explain that for me, please?
Under our omnibus services agreement, and the master services agreement that between Ascension and Central Health and the CCC, MAP eligibility is a reserved power that both partners, both parties, both Central Health and Ascension,
Have to agree.
have to agree to anytime there are changes made to that.
Got it. Thank you. I'll do Manager Valdez and then Manager Brinson.
I also am assuming that this money was also allocated for MAP and MAP Basic. Even though it doesn't say MAP Basic, because we funded $2 million in this very line item for the 2023 budget. I want to know whose idea was it to slash it in half, and why?
May I
Just
respond
curious.
to that, please? It wasn't a slashing
It's a cut in
exercise.
half.
Manager Valadez, please, we very much appreciate your advocacy, and we share in that advocacy in going from 6 to 12 months, but it wasn't a slashing exercise. We currently have dollars that are allocated in our primary care, specialty care, transitions of care, and other lines of care that we care for individuals that we're able to extend their enrollment by getting them re-enrolled after that 6-month period. And we do that today, and those dollars are in the budget today. That $1 million that you see is a calculation and a placeholder starting out such that if we can get from 6 to 12 months for the aforementioned reasons, then there's some margin there. But we're going to come back the next fiscal year because post
25.
transitioning from 6 to 12 months, if that's when it occurs in 24. And this board will have to consider perhaps allocating more amounts to specialty care and primary care and all the other lines of services that are spelled out. Again, this is just a placeholder to be able to provide a little bit of margin should we are able to transition at that point later in the year. But I assure you, it wasn't just an arbitrary slashing exercise.
Excuse me, sir, I never said it was an arbitrary decision. I wanted to know if it was in 2023. I don't know what it was in 2022 because I don't have that in front of me. But in 2023, it was $2 million. Jonathan, what was it in 2022?
I don't know, Manager Valdez.
Jeff?
Jeff may have that information.
Chair, if there's a sense of budget.
Either way, that was still the expectation of us as board members, at least me, as this board member, had the expectation that we would be able to see the efforts to be able to expand that number and to increase the eligibility from 6 months to a year.
Okay.
And as it was in 2023,
All right.
for 2024, we cut that in half.
Thank you. Manager Brinson.
I apologize if I'm reiterating what I stated earlier. I do not think we should be bringing up added budgets at this time. I think that trying to rely on the emotional aspect of this when people are tired, people need to think about these. These are important. Every patient we have is important. So I just can tell you that I cannot vote on that.
All right, thank you, Manager Brinson. Manager Jones.
2 questions. One is what Manager Valadez said correct? Was it 2023?
It's right here.
Okay.
It was $2 million
So
in FY
so what
23.
she's saying is reduced by 1 million.
Yes, that's
Can we
correct.
get an
For
answer
the
to
proposed
why?
FY '24 budget. So I can just give my perspective that at this point in the year, and up to this point, Ascension has declined to expand the eligibility to 12 months. So I think we want to have a placeholder there to signal this board's intent that that is a priority, and that's something that we want to pursue as an organization, but as mentioned before, it requires the approval of both parties. So there's an amount there for us to work with. Again, assuming that as of the first of the fiscal year, that change is probably not going to be in place, but leaving open the opportunity that could go into effect at some point in the year. We've made those requests several times over the past few years, and as recently as last week, asked if Ascension representatives were interested in pursuing that.
So what I'm hearing you say is that extra $1 million would not buy anything, it would just be sitting there if it was to approve.
Back to, I think, an earlier point that was made, that the analysis that we've done, and it's several years old now, so I don't recall all of the details of that analysis, but there are some savings aspects associated with extending enrollment, as well as additional costs. I think the summary of our analysis was that the majority of the additional costs would actually show up in some of Central Health's contracted services. So not even necessarily in this $1 million or $2 million line, but in our primary care agreements, in our pharmacy budget, and our other service agreements. And this $1 million or $2 million was intended to have a placeholder for reimbursing other providers should their costs exceed historical levels as a result of extending that enrollment period.
Well, just to close out, okay, you can respond to that, but Manager Brinson, I understand your frustration, you're tired, I'm tired too. But
It is not logical.
we are here to do the people's business.
Yes, we are,
And
but we
those
should
of us who
respect.
Those of us who are committed to the cause that others may or may not be committed
But
of,
you want
we have to-
decisions
we have to
made
stand up for
logically.
those. That does not imply that our positions are illogical.
No, I'm implying that you should not,
Okay.
all right, never mind.
Manager Martin, Manager Kitchen, and then Manager Montoya.
Thank you. May I please? I think it's important to understand that we're making large monetary decisions at a last minute. And I don't think that's professional. And I don't think it's respectful of the people we serve. These things should not be brought up at the last minute to ask for significant amounts of money for whatever the cause, and or to insinuate that if you don't support the cause, you somehow don't support the cause of Central Health, is unfair. I side with Dr. Brinson. These are big decisions to be discussed openly and with abundant time to discuss. We have a major issue to deal with tomorrow that we need to move on and decide on. And every time I want to add something else, it leads to more discussions when they should have been brought up with abundant time to discuss fully and at length with our purpose in mind. Thank you.
Manager Kitchen.
Manager Valadez, I wanted to suggest an alternative. Instead of a dollar amount, I think what we're saying is, and tell me if I don't mean to be interpreting for you, but what I'm hearing and what I would like to understand is if, at the point at which we're able to extend from 6 to 12 months, given all the challenges to that we would have sufficient dollars to do so. I think that we could just make a statement that clarifies that, since we don't know today whether that's $1 million or $2 million or whatever, but I think we're all probably on the same page, that we really want that 6 to 12 months and we want to be able to do it. So perhaps we could revise the language that you're thinking of to just say something to the effect that the Board of Managers is committed to extend the eligibility for our MAP patients from 6 to 12 months whenever we can do that, and that we are committed to having the funds available to pay that cost or something like that. Would that be acceptable as an amendment?
I appreciate that. I appreciate your words, your comment, and your spirit. And if what you're telling me is that you can count around this table that we don't have a majority of the board members that understand that contingency reserves of about $380 million, it's going to be a fiscal risk for us to remove $1 million and put it back to the level that 2023 had for MAP eligibility, then that's what I have to do for anything to be again included with the consideration for MAP and MAP eligibility.
So you refuse the revision?
No, I just would like to,
Let's get that.
I just want to know whether or not, if this doesn't fail, Ann, will you make that subsequent motion? If this fails.
Sure, I'll make the subsequent motion. I'm just want to cut to the chase, and I think it gets us to the same place.
Yes, thank you very much.
So you don't want to replace your
I would like to
motion.
have a vote
You have
first.
a vote up or down on
Yes.
this motion? Okay.
Yes.
Manager Montoni?
I was just going to ask about budget to actuals in 2023 with that, but I don't think it matters anymore. I'll just follow this process.
Then, all in favor?
Thank you.
Show Manager Jones, Valadez, in favor? All opposed? Anyone abstaining? Show manager kitchen as abstaining. And the amendment does not pass. All right,
I'm going to make that substitute.
recognize.
Okay, this item number 6 states the Board of Managers reiterates its commitment to extend MAP eligibility from 6 months to 12 months as soon as it is possible legally to do so, and will amend the budget if necessary to pay for such extension, to fund such extension.
Okay, I have a motion for an amendment on the table. Do I have a second?
I'll second it if you accept just a couple of words
Okay.
for eligibility and services.
Yes.
Or services.
Yes, yes.
Thank you.
Okay, I have a motion by Manager Kitchen. I have a second by Manager Valadez. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Show Manager Martin as abstaining. The motion carries. Manager Musaiti.
Thank you, Chair. Manager Kitchen, I would like to make 2 amendments to items number 1 and number 2. For number 2, rather than stating interlocal agreement, I want that to be service agreement.
Can I explain why I wouldn't want to do that?
Sure.
Maybe it could say interlocal or service agreement. I'd like the option to consider an interlocal agreement. That's why I use those terms.
I believe Central Health has an interlocal agreement with Integral Care.
Not that I'm aware of, but we could say interlocal or service agreement and still get to the same place.
Monica or Jonathan, whoever.
Central Health has more than one, but services agreements with Integral Care today, just to clarify that point. That's where we reimburse for
Yeah.
inpatient
We don't have an
psychiatric services. We reimburse for services for our patient population through the Herman Center and the MAT program that was stood up last year with Integral Care.
But we don't have an interlocal agreement.
No, and we don't have interlocal agreements for services.
Well, this is an exploration. I consider Integral Care to be a partner because they're another public entity, and I would like to have a conversation. That's all this is a conversation about an interlocal agreement.
I think it would be helpful for staff to understand the distinction. Typically in our discussions with service providers, we reimburse for services as they're incurred, and it's through the services agreement structure that we're able to define what that scope of services are, who the eligible patient population is.
Okay, so I can,
detail.
shall I go ahead and clarify? So the language is, we'll collaborate with Integral Care to consider development of an ongoing interlocal agreement to provide, mental, behavioral, and substance use disorder services for low-income eligible persons. An integral, I consider, Integral Care is a public body, and I consider the partnership to be important. An interlocal agreement allows more flexibility. The terms still have to be agreed upon. But it allows the flexibility to consider funding arrangements that might be appropriate. It is not as narrow as a service agreement. It could be written in such a way that it's essentially all the components of a service agreement. It's subject to agreement. Both sides have to agree. But I don't think that we should at this time say that we can only have a service agreement with Integral Care. And this is collaborate with Integral Care to consider. You all may come back to this board and say, no, we don't think an ILA is appropriate because, blah, 1, 2, 3, 4, and that's certainly acceptable to have that conversation. At this point, I want the purpose of this is consideration of an interlocal agreement, so I could not accept your amendment because it takes away the whole reason behind my amendment.
But would you accept services or interlocal?
Yes.
Yeah, well, I mean, we already have it. I mean, sure, that's fine. As long as there's as long as there's an effort to explore whether an
Consider
interlocal
it.
agreement works. Yeah,
Thank
that'd be
you.
fine.
Thank you.
Need a second?
Chair, to be clear, is the consider language in there then?
Yeah.
Yes.
Okay.
Yeah, the
Yeah,
consider
that's-
language would
So-
remain.
I can read it again. Yeah, that was there. Yeah, okay.
And can I state my other amendment?
Well, wait,
Oh.
We have to do one at a
we
time.
have to do one at a time. So in essence, we're gonna add services or interlocal.
I can read it. Let me read it.
Okay.
Okay. The Board of Managers is committed to continued partnership with Integral Care and will collaborate with Integral Care to consider development of an ongoing interlocal agreement or service agreement to provide mental, behavioral, and substance use disorder services for low-income eligible persons.
All right. And I have a second from Manager Brinson. So any further discussion? Hearing none, all in favor? Any opposed? Motion carries unanimously.
Thank you.
Okay, Manager Musaidi?
Yes, thank you. Manager Kitchen, to your first amendment, I would like to add additional language, and this language mirrors the language that was provided by our CEO on page 1, under item number 2, operational language to address. So the language that I would like to add is 1, substantial progress within 90 days to enroll individuals who are low income, uninsured, and residing in Travis County in a health program and connecting to Central Health's contracted or provided services, whether incarcerated or at risk of incarceration while in law enforcement custody at jail county facilities.
That's acceptable. I accept that.
And my second amendment, to that, I know initially I did not support an amendment to our current budget, but given some, the recommendation by our staff and some additional language, additional information that was shared, I would like to amend our budget to include 2 million for inmate health to our current budget.
Perhaps we should take those separately. One's
will.
Okay.
So those are my amendments.
All right.
So, thank
So
you.
on the first amendment, is the substitute language read in under number 1?
It's additional language, not substitute.
Additional, I'm sorry. Additional language under number 1.
Right.
And so I have a motion, I need a second.
It's fine.
Okay. I have a motion from Manager Musaidi. If I have a second from Manager Martin. Any further discussion?
Do you need me to read the whole thing again, or do people understand what it is?
Do we need her to read it again?
No. Number 1,
Number
jail
1.
services.
It's number
Yeah,
1 there. jail services.
she's, no, not the 2 minutes. She's adding language to, I wrote a sentence that's already in there.
Right.
She's adding language to that.
Yes, all the way until facilities.
We have that. If they heard it once, I can take both of them to make one.
Okay,
I was just asking if people,
Directly out of my stuff, read directly.
Yes.
right.
okay,
So
Okay.
just added
So
language.
are we
Okay.
clear what we're voting on?
I am.
Okay. I mean,
I just respectfully suggest that they be split into subpoints, that,
Fine.
that there's an A and a B or
A and
a
a
1
B.
and a 2.
oh yeah, that's fine.
Yes.
That's fine.
Yeah.
Okay. No further discussion? All in favor?
I had a comment.
Oh, I'm
sorry.
sorry, I thought you were voting.
I just
Sorry.
would like for everybody from here on out, after item number 6, to understand that some people are operating under very tired, fatigued conditions, and I apologize for that, but I just want everybody to know that we are all equal, and we're all here, and we're all struggling with the same issues. We're not here because we wanted to make last moment changes. We're here because we're trying to make sure that we get something passed that the Travis County Commissioners will support.
Thank you. Appreciate that. All right, any further discussion? Hearing none, all in favor? Any opposed? Motion carries unanimously.
The second.
And then your second amendment is to add $2 million.
That's to the budget, it won't be to this document.
Right, it will not be to that document, it will be $2 million to jail services
Correct, as recommended by staff.
as recommended by staff. All right. I have a motion.
Chair, and this is just a procedural question. Before y'all move on that, I do have proposed amendments to the to the jail services clause, and so they wouldn't necessarily have budget implications. I don't know how and when you want to take those up, but I just want to put that out
Yeah,
there.
yeah, Chair, I would suggest we need to finish this resolution before we turn to the budget, because that's a different subject.
Okay,
So,
so Manager Matwani.
Totally agreed with the existing language at this point as amended, and would like to further delineate within, add language to the study portion of it, basically. And that language is that, I would maybe split the study into 3 subpoints, but that study would include, but not be limited to, the assessment that's already been identified. And then second, historic and current analysis of most common conditions, causes of conditions, including if they're pre-existing, treatment efficacy and final outcomes of those conditions historically. And then the third point in that study would be a cost analysis, including funding sources and billing providers, specifically including a review in the interest of both fiscal analysis and accuracy, including but not limited to healthcare services billed by providers to the Medicaid funding source when applicable for eligible patients, and services billed by providers at list price or non-insured market rates.
I accept that amendment.
All right, so I have a motion for an amendment. He's gonna need, yeah, you're gonna need to email the wording to him. I don't blame you. And I have a second from Manager Kitchen. Any further discussion? Manager Valadez.
I don't know how, I think what I want to get to is whether or not, oh, thank you, I'm sorry. Whether or not, or ask if we can do also, is it going to be second, an analysis on our, other than community care or enterprise providers, how much we're paying them and how many people they're seeing. Because as we have had to deal with new providers and new providers and new providers from all these for-profit and not-for-profit clinics that are providing services, I'd like to know who is going to the for-profit clinics at what time of the day. The same thing for the not-for-profits, other than community care and People's or whatever. But just have an analysis of that.
Mr. Giesland?
Yep, Manager Kitchen.
Oh, I'm sorry.
Maybe that's a different, we're talking about jail services now. I think you want something broader
Well,
than that?
Only because what we talked about was the analysis, but,
But you want something broader than just jail services, don't you?
oh, yes,
Well, then maybe we take that up separately?
thank you.
Manager, excuse me.
Just Mike.
Mike.
Yeah.
Mike
No,
Giesland.
thank you. Well, we actually provide that information to the board extensively, and it's in the utilization reports that we, in the service reports, and you'll recall Sarita Clark Leach and others that had provided that information. And I think looking forward, if there is, we always come back to the board each year and say, these are the sorts of things we reported on last year, what else is there? But I think using that process, as we sit here today, I'm not sure what else we could bring back to the board. And just trying to read into your comments there, Manager Valadez.
I know I've asked for this before, and if somebody can forward me the latest utilization, I'd appreciate it. But what I'm looking for is disaggregated data with respect to what the individual providers are providing to our patients.
Okay.
Because that's what we're paying for.
And have that discussion also.
Yes,
Yeah.
thank you.
Appreciate that. All right, so we have a motion and I have a second. Are we ready to vote? Does everybody understand what we're voting on? Okay. All in favor? Any opposed? Any abstaining?
Which one? Sorry.
For Manager Motwani's, yeah, you're for it.
Yes.
Yeah. Motion passes unanimously. Okay. Any
So-
more?
Okay.
Yeah, Mr. Geeson.
Well, barring no further motions to amend, we really need to take, and I know it's late, a recess to capture everything that's been discussed, put it up on the screen so everybody can see it, to make sure that we got this right before we leave here.
I got it.
Okay, let's go ahead and vote on,
Yeah,
vote on.
Yeah. I
with
just
this
want
whole
to
thing.
build that into the schedule, sir.
Right.
Thank you.
Okay.
So now the motion is to vote on the entire amended
Yeah,
language.
motion, the original motion as amended, yeah.
Yeah. So the original motion as amended, I need a motion. Manager Kitchen.
Actually, it's on the floor already, so you just need a vote.
Oh, that was the last.
Oh, that was the first, okay.
These
I
were
got
the
it.
amendments.
All right, so now we're voting on the motion as amended. Any further discussion? Hearing none, all in favor? Any opposed? Any abstaining? You're opposed? No. Oh. Any abstaining? Motion,
I think I better abstain.
okay, so I have Manager Valadez abstaining. Okay? Motion carries. All right, now
The budget.
we need budget amendment. Manager, I recognize Manager Musaidi.
Thank you, Chair. Members, I know we've added additional language. We amended the language to our budget resolution. But in addition to that, based on some recommendations that we received from staff and discussions, I would like us to amend our current budget to add $2 million for inmate health.
Okay, I have a motion. Do I have a second? Manager Martin seconds. So a motion by Manager Musaidi, but second by Manager Martin. Any further discussion? Manager Jones.
Just a question, in terms of the 2 million, so what is the deliverable do we anticipate getting? What we just discussed?
Staff, can you,
Actually, I think I can handle that.
can you?
I think the deliverable is, we currently do eligibility in the jail. So we would support additional services to determine the eligibility of the inmate coming into the jail. And then if those inmates qualify for a MAP program, then we get billed for those services
Okay.
and the county won't have to pay.
Okay, all right, thank you.
Does that make sense?
Dr. Bell,
Yeah.
if I could just clarify,
Sure.
so we had the discussion of member reserve powers related to eligibility. Individuals who are incarcerated are excluded from the MAP program. So it will have to be a program other than the MAP program that we are enrolling individuals into. The work you described, Dr. Bell, we're doing for continuity so that as soon as someone is actually released from jail, they're in the MAP program. We work with the transition center and get them connected to care.
Okay.
But
So they're not really
it wouldn't
a
be
member
enrollment
of the
into MAP, it would
program.
be
That's right.
enrollment into a different program.
Exactly.
And I think our goal with that $2 million is to help inmates access specialty care that they are not able to access reliably today through the use of our network agreements. So we're trying to extend those where we can. We would have to create this enrollment program, and then we would have to work with our contracted network of providers to add this program to those services agreements so that we can help supplement the care that those individuals are able to receive in the jail.
Thank you. And
Would
if I
these,
may?
would these patients be eligible for MAP Basic, which is not MAP, it's MAP Basic?
I think that's one of the things that we'll take a look at. I'm not
Legally?
prepared to answer that today, but that
Okay.
is one of the options I think we'll
Thank you.
evaluate. Yes, ma'am.
And if I may, and this also reiterates our commitment to pursue this further, and hopefully with our studies and with the resolution that we've added, the additional language to our budget resolution, that we can have a more thorough discussion how we can best deliver care for our inmates in Travis County. Thank you.
Agreed. Manager Kitchen and then Manager Branson.
So, question, so this is 2 million only to this first budget, right?
Correct.
Manager Branson?
And you want the 2 million not to be spent now on patient care, but to develop the plan.
It's both.
Dr.
Well,
Brinson, we anticipate that 2 million could be spent on care this year that we would arrange for some of those individuals through our network of providers.
But we could arrange for money at a later date, we don't have to put monies in, how am I going to say this?
I think what you're trying to say is that part of those monies, part of the 2 million, she'd like to make sure is spent on an analysis of the program. And then the rest of that 2 million would be spent on the services that you just
If we
outlined.
agreed with the services, because, I'm very hesitant to start even walking into this water until we have a pretty good idea what we're walking into, just my opinion.
And it would be pursuant to contracts, it would be pursuant to, to eligible patients. So it, allows us to, I think, do the exploration that you were suggesting, as well as meet the stated goals.
Manager Kitchen.
I'd like to clarify, if this is the intent, that this is, I would like to call it a pilot, that it is not a commitment to an ongoing, it is not a commitment to taking over responsibility for those services, and it's not a commitment to continuing, that it is a pilot subject to the results of the study.
Okay. Mike?
If you're talking about enrolling the eligible population, which we would do whether they were incarcerated or at risk of incarceration, how does the assessment line up?
I thought we
With
were
what?
talking about paying for dollars while they're in the jail. That's the
correct,
part, that's
yes.
the new part. Because we don't do that now, right?
And they're also talking about paying for pharmaceuticals and testing. And I suppose if they were eligible and they went to the hospital, they would pay for all of those services. No. Oh, but that would be Seton. Yeah.
Yeah, no, that is not what we're talking about.
I'm willing to put some dollars into trying this year, but I don't want us to get into a position of making a commitment or this being interpreted as us taking over a service that the county currently provides without them giving us tax dollars.
I agree with that. I just am very hesitant. I don't mind spending the money to figure all of this out, but I'm just telling you, it's a snake pit.
And I would say, I think that this is a good faith demonstration of Central Health's willingness to pilot these services as we are moving forward with this broader exploration that you were discussing.
I agree, and that is really the intent. Just, I think we're all on the same page.
All right. Manager Valadez?
Very quickly, and I personally would be supportive of this because I know so many children of family members who are in jail, who are incarcerated, who have been traumatized, who have suffered from and are suffering from right to this day, and it just it increases exponentially depending on how long or in and out situations of their family members or parents. Mental, the aggravated mental, behavioral, and even physical manipulations or physical manifestations of what they're feeling emotionally and psychologically. So this is long overdue.
Thank you. All right. Any further discussion? Hearing none. All in favor? Any opposed? Any abstaining? Motion carries unanimously. All right, members. We will take a recess while the staff draft the changes to the resolution and provide us with a copy that we can approve. If you can stay with us, we appreciate it. If more than If more of you leave and I don't have a quorum, then in essence, the meeting stops.
How long is this gonna take? This it all depends on the.
Jeb? Do we need an amendment?
It was kind of
It was in, that's right. Budget for your 500. It was in the resolution, but we need a separate amendment to the budget.
Before the recess?
Huh?
Did you say before the recess?
Before the recess.
Before the recess. Okay, fair enough.
Can I go to the bathroom?
Oh, Chair Bell?
Thank you.
Huh?
Oh, we're not recessing.
We're gonna recess. We'll come back. back from recess. We are continuing to deliberate on agenda item number 1. Board members have a copy of the amended resolution language that we voted on. And I am open for any concerns that you see on that document. Manager Musaiti.
Thank you. So for the amendment number 1, B, the last sentence, the board amends the budget to add $2 million to fund supplemental health care for eligible Travis County residents for the purposes stated above. I'm not sure if this language states it as a pilot, so I just want that amended if we can. Thank you.
To fund, so in essence,
For
you'd like
fiscal-
to fund supplemental healthcare pilot
For fiscal year 2024.
for fiscal year 2024.
that's why we explore.
Yeah.
Okay? Staff, do we get that?
Do you all agree?
Yes, yes, I agree. Manager Matwani.
If the $2 million are to be used for my question is, are the $2 million to be able to be applied only to the item mentioned above, or all 3 of the items, or rather the item below as well? Because I think the intent of that study was so maybe C could be bumped up to B and B would be bumped downward if we're going to use the above language.
Look at, you could just say for the purposes stated in this, in sections A, B, and C.
And so, yeah,
So
You could,
section 1.
Go ahead,
No, go ahead,
Manager.
go ahead.
Manager
You
Kitchen.
could state, for the purposes stated in A, B, and C. You gotta get the pilot language in too, though.
So maybe perhaps we can move B to C, and then that kind of, in terms of the order,
Well, yeah, if you wanna do it that way, that's
it's
fine.
cleaner. Don't you agree?
Okay, that's fine.
Because
So you got that, David?
I'm just thinking.
Okay. Any additional?
What does it say now, David? Is it up there?
Yeah.
Pilot, we wanted the word pilot in there. To fund a supplemental healthcare pilot.
For fiscal year 2024.
Yeah.
And then you gotta fix for the, yeah, she's moving it, she's moving it.
Okay.
Okay.
Anything else?
I just want to make
Manager
sure,
Jones?
I just want to make sure under item 4, that's an additional, that is add additional 500 to what was added before.
So in essence, what you're saying is there's an additional 500 that's in there already.
Right,
So you want this to be clarified that this is an addition above that.
right.
All right. Does that,
Bring it to a total of
a million
800 and,
or whatever?
yeah.
No, it's $1 million. It's $1 million.
No, it was 500,000 is already in there.
Yes, with the original budget.
Right. So we're adding an additional 5 to that.
So it's $1 million.
So total, yeah, total went from last year and this year, yes.
And we would need, if I may, 500K should be taken out to read 500,000. Yeah.
Manager Misaji.
Manager Kitchen, under 5, you said over a period of time. Do you want to specify that time?
Well, we didn't vote on it, I just said a period of time, so. if-
Because it's very broad.
I know. If someone wants to suggest a change, we'll probably have to vote on it, but which is fine with me if you want to do that.
Okay.
How about just
I-
eliminating over a period of time, just to accelerate the implementation of the project?
Yeah, you could do that. I mean, that's, this is what I,
So we're not waiting for the 7 years.
that'd be better.
Mike,
Okay,
you tell her to take that up.
So you're scratching over?
Oh, I see.
over a period of time.
Okay. Yes?
Yeah, we have LCH, Latina Healthcare Forum. It
that
wasn't the forum, it was for Latina healthcare efforts.
That's right.
Did they catch that? Let's see.
Work with Latina
Yeah.
healthcare.
Did you-
LCH, that's Latino Healthcare Forum, and that's not what I said.
Oh, it's not.
No,
Somebody was listening to this, I'm sorry. What did you say?
I said it was to focus on Latino and non-English speaking populations. When I spoke originally about Latino Healthcare Forum, it's because they were the ones that were first talking about diversity, equity, social determinants of health,
And-
disparities.
And then number five should take, after accelerate, number five. Take
Take
out
out.
over a period of time. There you go. Okay. Okay.
Any other changes?
Number 6, I think it's a typo. The Board of Managers reiterate its commitment.
Yeah, it should be commitment.
It's committed. Commitment to extend.
Number 6.
She's got it.
So it's like.
Yeah, there you go.
With 9 people. Any other comments or questions? Mike, did you want to read something into the record?
Yes, sir, if I may, and I would encourage the board to take a vote just to recognize this document as being the final version, just again for the record, but consider these statements a management statement, but as follows: the inability to obtain needed tax revenues and manage reserve allocations over a reasonable period of time will result in a reconsideration of the aforementioned priorities and likely delays or cancellations of initiatives, including the healthcare equity implementation plan that impact current levels of care and future enhancements to the healthcare system for low-income persons of Travis County. Members, the reason that I would respectfully request that this be included in the minutes is to reflect for future purposes, what some of the concerns are with how, we've been scrambling over the past few days to try to rework some things, but also what's at risk, which is a high-functioning healthcare system. And so further disruptions or adverse actions to the healthcare financing strategy of the hospital district will make it more difficult to achieve the goals that the board is set forth. So that's the reason for reading it into the record. Thank you.
I'm sorry, Mike, can you read it again?
Yes. The inability to obtain needed tax revenues and manage reserve allocations over a reasonable period of time will result in a reconsideration of the aforementioned priorities and likely delays or cancellations of initiatives, including the healthcare equity implementation plan, that impact current levels of care and future enhancements to the healthcare system for low-income persons of Travis County.
Mike, what are we assuming a reasonable period of time is? I'm sorry, Mike, what are we assuming a reasonable period of time is?
Well, what we showed you earlier this evening, again, starting with the original financial forecast that takes it out to 2030, that's one reasonable time period. Another reasonable time period is adding the additional costs for, at the request of the Travis County Commissioners Court, which actually has us hitting our days of cash on hand target 1 year earlier in FY '29, although that's still reasonable, a little riskier, but still reasonable. But once you start accelerating the depletion of the reserves in over 2-3 year period, it jeopardizes our overall healthcare financing strategy to be able to implement on a high functioning healthcare system.
Manager Kitchen.
I'm a little concerned about this language because it says likely delays or cancellations of initiatives. I feel like this is more than I would feel comfortable saying. I would feel more comfortable just saying failure to obtain needed tax revenues. And I don't know why we have managed reserve allocations in here. I would just say failure to obtain needed tax revenues. Will result in a reconsideration of the aforementioned priorities or period or something like that. I don't like the likely delays or cancellations of initiatives because I'm not prepared to say that.
Well, you wouldn't be saying it, all right? It's, with what I understand,
Okay.
this is a management
Oh, well, if it's just
statement
management
to
reading.
us.
Okay, that's fine.
And this is what I'm reading into the record, and it'll be in the board minutes.
That's
And
correct.
Oh, yeah, well, you're
perhaps it might be
entitled,
useful in the future at some
yeah,
point.
you're entitled to read whatever into the budget you want as.
It's not for us to say.
Okay, great, that's fine. I just wanted to note that because.
Okay, Mike?
Thank you.
All right, so we're gonna take, unless I have any other comments, and I think everybody has read and is comfortable with this document. So this document, I need a motion to insert the following, to approve this insertion into the Central Health 2024 budget resolution and renumber as appropriate. Do I have a motion? Manager Kitchen. I have a motion from Manager Kitchen, a second from Manager Musaitis. Any further discussion? Hearing none. All in favor? Any opposed? Any abstaining? Show Manager Valadez is abstaining. The motion carries. Agenda item number 2. Confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, October 25th, 2023 at 4 p.m. at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. Manager Motwani moves adjournment and Manager Valadez seconds. Any further discussion? All in favor? Any opposed? We are adjourned. Thank you.